I am Dr. Serous, and I welcome you all in pre-Symposium-Pathology Workshop of 19th Annual Symposium of Shaukat Khanum Memorial Cancer Hospital and Research Center. Today, we have two sessions. In the first session that will end at 2 p.m. and start right now, we have two lectures of Dr. Xavier, who is Professor and Chair of Pathology at University of Lleida and University Hospital, Barcelona in Spain. He did his subspecialty fellowship in molecular pathology at New England Medical Center in University of Boston from US. His research focused on clinical pathological features and molecular genetics of gynecological malignancies. He has special interest in endometrial and ovarian cancers and circulating tumor DNA in gynecological malignancies. He is author of over 300 publications and member of several editorial boards. He was a member of Executive Committee of International Society of Gynecological Pathologists. He was also a member of WHO panel for classification of tumors of the female genital tract. His first lecture would be on endometrial carcinoma, WHO classification and molecular classification. And second lecture would be mixed epithelial and stromal tumor of uterus and update. And I have a request to the participants. Please send your questions in question and answer box, and answers will be given at the end of this session. Now over to Dr. Xavier.
Mudassar Hussain for inviting me to give these two talks. It's really a pleasure to be with you. Unfortunately, I'm not in Pakistan, but I think it's going to be okay. And as said before, in this first talk, I'm going to discuss with you endometrial cancer, WHO classification, and also the molecular classification. There is recent development in this field. So let's go into pathological classification, and then we'll go into the molecular classification. And as you probably know, 1 month ago, maybe 2 months ago, the new WHO classification was published, the 5th edition. Here you have the picture of the editors of the different chapters. It was an honor for me to be chairing the section on endometrial carcinoma. And this is the classification that we have. Is similar to the previous one with some subtle changes. We have endometrial carcinoma, serous carcinoma, clear cell carcinoma, undifferentiated, dedifferentiated carcinoma, mixed carcinoma, others, and carcinosarcoma. Carcinosarcoma is going to be discussed in the second talk. And then we have also neuroendocrine carcinoma. So what I'm going to do is just briefly review the pathological features of each of these entities, particularly focus on the most of the youngest pathologists. So this is endometrial carcinoma. It's the most frequent type of tumor. It's characterized by cells that are arranged in a glandular pattern, mimicking what happens in the normal proliferative endometrium. Very important in endometrial carcinoma is to separate, to distinguish between low-grade tumors and high-grade tumors. And WHO classification recommends to put together grade 1 and grade 2 in contrast to grade 3 carcinomas. That's because clinicians like this, and also because there is poor inter-observer reproducibility in the distinction between endometrioid type 1 and type 2. We have variants, and variants in the book, in the WHO book, they are called patterns. These patterns are not important in terms of prognosis, but for us as pathologists are important to be recognized because they can cause troubles in diagnosis. Obviously, we have tumors with squamous differentiation. That's probably the most frequent pattern that we see. They are seen in low-grade and also in high-grade tumors. And then we have tumors with papillary arrangement. It's what is called villoglandular pattern. There is a little bit of controversy in the literature, but they are usually associated with the same prognosis as conventional endometrial carcinoma. They have slender papillae, columnar cells, smooth apical luminal border, and low-grade nuclei, which are polarity. This is the typical picture of endometrial carcinoma with this villoglandular pattern. This is another pattern which sometimes cause troubles in young pathologists, is the endometrial carcinoma with small non-villous papillae. Sometimes people misinterpret this variant, this pattern, as serous carcinoma. The tumor is composed of small pseudopapillae lacking fibrovascular cores and typical polygonal cohesive cells with abundant cytoplasm, eosinophilic cytoplasm are seen. And this is quite a typical picture of this, that this is usually a focal pattern in the setting of a conventional endometrial carcinoma, but this can cause troubles in differential diagnosis. We have two other patterns, the secretory, the ciliated. They are usually easy to be recognized, the secretory with these subnuclear vacuoles that mimic what happens in the secretory endometrium. And then we have two also interesting patterns. One is the microglandular, that mimics microglandular hyperplasia of the cervix. And the other one, which is more frequent in endometrial carcinomas of the ovary, is the sertoliform pattern. The microglandular may be tricky. It was described many years ago by Dr. Young and Dr. Scully as uterine carcinoma simulating microglandular hyperplasia, because, you know, on the other side, sometimes when getting a sample from the endometrium, you can take samples, you know, material from the cervix, and you can obtain microglandular hyperplasia of the cervix in an endometrial biopsy. So that differential diagnosis between microglandular hyperplasia of the cervix and uterine carcinoma simulating microglandular hyperplasia can occur. And then there is this funny tumor, endometrial carcinomas with sex cord-like formations and hyalinization, but I will discuss that variant in the next talk when discussing carcinosarcoma. And then we have mucinous carcinoma. In the previous WHO classification, mucinous carcinoma was interpreted as a different variant of endometrial carcinoma, but you know, it's basically the same type of tumor. The epidemiological data shows that the risk factors are identical, and even the molecular features are identical, but there are subtle things that we have to take into account. So mucinous carcinoma of the endometrium is now a pattern of endometrial carcinoma because it has the same prognosis and the same risk factors as endometrial carcinoma. In fact, there is a spectrum of endometrial carcinoma with different amounts of mucinous differentiation, and mucinous carcinoma is just at the end of this spectrum. The tumors have KRAS mutations, which are not unusual in endometrial carcinomas, but they have a tendency in some series to develop lymph node metastasis. So it's well to take that into account. And sometimes it's difficult to make the diagnosis, particularly in small biopsies, because the differential diagnosis with proliferative mucinous lesions is always there. And just to remember that there are several papers emphasizing the difficulties in small biopsies of distinguishing between atypical mucinous glandular proliferations and mucinous carcinoma. Probably the best advice is to be rigorous, but also to be concerned when there is a glandular typical mucinous proliferation in a postmenopausal patient in the absence of, without the setting of a polyp. In that situation, you know, chances are that this can be related to a carcinoma. And this is an example of one of these lesions, very indolent, difficult to be diagnosed in biopsy, but then in the specimen there is an obvious endometrial carcinoma with mucinous differentiation. In endometrial carcinoma, we have also interesting patterns. We have a pattern which is called adenoma malignum, and we have the MELF pattern. So this is the adenoma malignum, sometimes the tumor infiltrating the myometrium without a desmoplastic reaction. And this is the MELF pattern. And for those pathologists that are young, it's very important to recognize that pattern because the cells are elongated, are flat, sometimes with this fibromyxoid reaction, sometimes with inflammatory cells, and they can be overlooked. And it's important in terms of measure the level of myometrial invasion. It's very important also because this pattern, which is not clearly associated with prognosis, at least, at present, is associated with lymph node metastasis, and metastasis in nodes is typically with a pattern that can be also overlooked. Tumors with MELF pattern of invasion have this histiocyte-like pattern that the tumor cells can really mimic histiocytes. So we have also high-grade endometrioid carcinoma, which is a different tumor. It's a tumor that has a solid pattern with focal gland transition, and we have to make that diagnosis in a solid tumor. We have to see the endometrioid features. So this is, for example, a case. You can see this solid arrangement with some glandular typical endometrioid appearance. In this case, we can see the solid pattern with squamous differentiation, which is obvious evidence of endometrioid differentiation. And here you see a solid high-grade endometrioid carcinoma in association with this papillary low-grade component. So this is endometrioid carcinoma that accounts for 70% of the tumors. It's the most important type of tumor, and we have to be able to recognize all different patterns. But we have the bad type, which is serous carcinoma. And serous carcinoma is a tumor that is characterized by the presence of highly atypical cells and prominent cellular stratification in budding. The tumor is frequently associated with papillae, and that's the reason why in the former literature, it was designated as papillary serous. But now we have recognized that the tumor can be solid and can be even glandular. So this is the typical appearance, the papillary arrangement with cells that are highly atypical. But here you have a tumor that can be misinterpreted as a low-grade endometrioid carcinoma because you see that there is this prominent glandular arrangement, but also you can see that the cytologic atypia is very important. Whenever you have a tumor that looks endometrioid, low-grade endometrioid, a low magnification, but has highly atypical cells, chances are that this is going to be a serous carcinoma. And whenever we have this glandular pattern, we have to look for these slit-like arrangements, which are quite typical of serous carcinoma. And in addition, serous carcinoma has sometimes a solid pattern. And whenever that pattern is seen, the differential diagnosis with high-grade endometrioid carcinoma is considered. But serous carcinoma usually has higher cytological atypia. And it's very usual sometimes to look for the non-invasive component, formerly called endometrial carcinoma, which you see here at the surface, but because that can help in recognizing that tumor. Let me make one comment. In the previous WHO classification, endometrial intraepithelial carcinoma was considered as a different entity, just to alert on the possibility that even being non-invasive, the tumor may be associated with peritoneal spread, but it's just a variant of serous carcinoma, and in the current WHO classification, it's considered just a variant of serous carcinoma. But remember that non-invasive serous carcinoma can be associated with peritoneal spread. And if endometrioid carcinoma has this MELF pattern of invasion, it's important to remember that the serous carcinoma type has this gapping gland invasion, which is composed of cells, sometimes arranging glands, sometimes with this hobnail configuration, with sometimes little desmoplastic reaction. And let me just remember, because we will comment on that later on, that frequently serous carcinoma has clear cells. But this is not a mixed tumor. This is not clear cell carcinoma. This is just serous carcinoma with clear cells, which is quite frequent. And you can see that there is pseudostratification. Pseudostratification is not, as I will repeat in a few minutes, is not a feature of clear cell carcinoma. And just to remember this, sometimes serous carcinoma is non-invasive. Sometimes serous carcinoma is seen in the setting of a polyp, but whenever we see that, there is the possibility that the tumor has spread into the peritoneum, and that should be taken into account. This is an example of a serous carcinoma involving a polyp. You can see by P53 illustrating the tumor cell component. And this is the peritoneal metastasis that this patient had. So a serous carcinoma, non-invasive in a polyp with peritoneal spread. And very important in this setting, in the peritoneum, WT1 is very important. A serous carcinoma in the peritoneum that is P53 and WT1 positive, that goes for an ovarian high-grade serous carcinoma. But if the tumor is P53 positive and WT1 negative, that goes for serous carcinoma of the endometrium. There are many exceptions, but this is an important rule. Because it is, and it's very important to remember on the other side, it's very important to remember that also high-grade serous carcinoma of the ovary may metastasize to the endometrial surface. So the differential diagnosis of serous carcinoma of the endometrium is also endometrial involvement by high-grade serous carcinoma of the ovary. And let me show you a case in point. That is a patient with vaginal bleeding. The biopsy was taken. It was clear that it was a high-grade tumor with solid arrangement. There was atypia. The tumor was positive for P53, so the possibility of a serous carcinoma of the endometrium was there, as you can see here. But then the tumor was strongly positive for WT1, and at the end, the patient had a high-grade serous carcinoma of the ovary with extension into the endometrium. So this is something to be considered. And there is also another differential diagnosis of serous carcinoma that has to be taken into account. Endometrial polyps are frequent, and sometimes endometrial polyps undergo infarction. And when they undergo infarction, like in this case, the epithelium can have some changes that may really mimic serous carcinoma. And since serous carcinoma, as I have mentioned before, frequently occurs in the setting of polyps, that can give rise to problems in differential diagnosis. So I have discussed endometrial carcinoma, I have discussed serous carcinoma. Endometrial carcinoma represents 70%, almost 80%. Serous carcinoma, 15%. So it's basically, this is basically endometrial carcinoma. They are usually different tumors, easily to be distinguished one from the other. The vast majority of endometrioid carcinomas are low grade. The vast majority of serous carcinomas are papillary. But however, we have problems. To help us, we have immunohistochemistry. And there is not a single immunohistochemical marker, but we can use P53, which is positive in the vast majority of serous carcinoma, but also positive in a third of high-grade endometrial carcinoma. We have P16, which is important. And some people, including myself, also uses immunohistochemistry for P10 and for ARID1A, which are very infrequently negative in serous carcinoma. So that's very important. And also, it's important to take into account microsatellite instability. The presence of microsatellite instability, so negativity for mismatch repair proteins, is very unusual in serous carcinoma. So just to remember a little bit the patterns of immunostaining that we have for P53, we have 3 patterns. Whenever the tumor is strongly positive, this is what we call a mutated pattern. When the tumor is absolutely negative and we have internal control, so occasional fibroblasts that are positive, this is the null pattern. This is also a mutated pattern, while the wild type pattern is the one that we have here, in which some cells are positive, some cells are negative, and there are different intensities in the positivity. This is important to remember, to classify, to interpret appropriately P53. So endometrioid carcinomas and serous carcinomas, endometrioid carcinomas and serous carcinoma are different tumors. In fact, they have different tendency, for example, to metastasize to the omentum. So, and they have different precursor lesions. So they are different, but distinction is not always easy. They are different tumors. Whenever we use molecular tools, we can recognize that they are really different by mutation profile, by expression profile, by metabolomic profile. But sometimes differential diagnosis is not that easy. Whenever we have these problems to distinguish between high-grade endometrioid carcinoma and a serous carcinoma, we have to look for obvious endometrioid or serous features. So in the era of molecular pathology, sampling is still important. We have to use immunohistochemistry, as I have mentioned to you before, and as I will comment later on, molecular pathology may be important. Because when the tumors become solid, this differential diagnosis is more difficult. And this is a paper that was published by my friends Beck Gilks, Esther Oliva, and Rob Soslow, showing that when the tumors are really solid, inter-observer agreement is not very good. And that's because we have really a gray zone in between endometrioid and serous carcinoma. So we have low-grade endometrioid carcinomas. They are easy to be diagnosed in the vast majority of cases with the tools that we have. We have grade 3 endometrioid carcinoma in red. We have clear cells carcinoma. We have serous carcinoma. But in between, there are tumors that are difficult to be classified. This is the area in which there is poor inter-observer agreement. In that area, we have mixed endometrial carcinomas. We will discuss them in a few minutes. We have polymutated tumors. We will discuss them when we will discuss the molecular features. And we have ambiguous carcinoma. This is a term that was coined by Rob Soslow, but you know, there are tumors that are just impossible to be classified. Let me show you one of these. This is a carcinoma in the uterus. It's not endometrioid, it's not serous, it's not undifferentiated carcinoma. And even when we perform mutational profile, the tumor do not has any of the 20 most frequent mutation of endometrioid carcinoma and none of the 20 most frequent mutation of serous carcinoma. So it's impossible to be classified. They are very infrequent, less than 1%, but we have to be aware that they exist. So we have also clear cell carcinoma. And clear cell carcinoma is nowadays an infrequent type of tumor. The tumor is obviously composed of clear cells, but remember, clear cells can be seen in serous carcinoma, clear cells can be seen in endometrioid carcinoma. Sometimes clear cell carcinoma has a few clear cells and has this hobnail appearance. We have to be rigorous in making such a diagnosis. We have to look for admixture of patterns, the same patterns that we see in ovarian clear cell carcinoma. The cells are clear or eosinophilic. There is typical low mitotic index. Cell stratification is unusual. If there is cell stratification, chances are that this is going to be a serous carcinoma. And we have hyaline bodies, hyaline papillae, and hobnail cells. And we have the help of immunohistochemistry. The two typical markers are racemase and napsin A. Sometimes the tumor is positive for estrogen receptor, and sometimes the tumor has a mutated pattern for P53. But if you have a tumor that is strongly positive for estrogen receptor, or a tumor that is strongly positive for P53, please take an additional look. Be sure that this is clear cell carcinoma. Can be, but this is something to be taken into account to emphasize the differential diagnosis. And that it's a paper that we published together, a huge group of researchers, together with Daphne Bell, who is a researcher in NIH in Washington. And that's very interesting because we gather a huge series of clear cell carcinomas and we published and we screen them from the molecular standpoint. And clear cell carcinoma, by using rigorous criteria, is still a heterogeneous group of tumors, with tumors that are very similar to endometrioid carcinomas, tumors that are very similar molecularly to serous carcinoma, tumors that show combined features of both, and tumors that are different to serous and endometrial carcinoma. So still, even being rigorous, this is a heterogeneous group of tumors. And then we have undifferentiated and dedifferentiated carcinoma. This is the same tumor. It's an unusual type of tumor characterized by solid sheets of epithelial cells, sometimes with plasmacytoid-like features. That's important because some people make the wrong diagnosis of plasmacytoma when analyzing these tumors. The tumor is usually monotonous, necrotic, mitosis. The tumor is frequently almost negative for keratins and almost negative for EMA. This is something that has to be taken into account because this tumor is sometimes misinterpreted as a high-grade sarcoma because of the negativity, almost negativity for these markers. This is solid, but it's different from high-grade endometrioid carcinoma. And the tumor is negative for ecadherin, negative for PAX8, and frequently almost 40% of the tumors have mismatch repair deficiency. So this is the microscopical appearance. Is solid, but it's blue, while the usually high-grade endometrioid carcinoma, which is also solid, is pink. That's because of the monotony of the cells. That's at low power view, you can more or less recognize that pattern. There is focal positivity for keratin and for EMA, but very just focal. And again, this is a paper that we published with Dr. Palacios and also Rob Soslow and Esther Oliva a few years ago. And still also, this is a group of tumors that are heterogeneous, and we will go back into that when dealing with the molecular features of endometrial carcinoma. Just to mention that there is a subset of undifferentiated carcinoma in which you can find minor areas of low-grade endometrioid carcinoma. Low-grade endometrial carcinoma is the precursor lesion of this undifferentiated carcinoma. The people from MD Anderson used the term dedifferentiated carcinomas. This is a case in point. You see the gross, you see the low-grade picture, the undifferentiated feature. They are clonally related, so the undifferentiated component arises from the low-grade component, but the prognosis is identical as undifferentiated carcinoma. This is just a pattern of this type of tumor. And then we have mixed carcinoma. Mixed carcinoma is a tumor that has at least two patterns. And as mentioned before, this is a group of tumor that is somewhere in between, obviously, low-grade endometrioid carcinomas or high-grade endometrioid carcinomas and serous carcinoma. This is an infrequent type of tumor, should be infrequent. If you are diagnosing mixed endometrioid, non-endometrioid carcinomas frequently, chances are that we are too generous. That diagnosis should be made with caution and rigor to avoid misdiagnosis of mimickers. Any proportion of serous carcinoma should be reported. They are clonal, so in the vast majority of cases, and molecular features are poorly understood. So this is the most beautiful example that I have ever seen. You see the serous carcinoma decorated by the positivity for p53. You have the low-grade endometrioid carcinoma, which is negative for p53. And in this case, we performed molecular analysis and we demonstrated that the two components were clonal. This is the typical example of mixed endometrioid serous carcinoma. But we have to avoid mimickers. And the most frequent mimickers are first, endometrioid carcinomas with mixed conventional and papillary patterns. They have different patterns, but they are endometrioid carcinomas, not mixed tumors. Serous carcinomas with mixed conventional and glandular patterns. They have different patterns, but they are serous carcinomas. Then something that is very interesting, endometrioid carcinoma with surface changes. We're going to go into that in a few minutes. And then the tumors that have these two molecular abnormalities, polymutations and microsatellite instability. So this is surface changes. Sometimes that's particularly frequent in biopsies. Sometimes at the surface of an endometrioid carcinoma, you can have these patterns, hobnailing, atypicality. This is probably ischemic, but that can be misinterpreted as a serous carcinoma in the setting of an endometrioid carcinoma, so a mixed tumor. And just let me mention this. We will go back into that at the end of the talk. Tumors with polymutations. Tumors with mismatch repair deficiency are endometrioid carcinomas, but they are heterogeneous. They have areas that can be misinterpreted as serous carcinoma. And that's also something very important in diagnosis. We will go back into that in a few minutes. And this is just a polymutated tumor. You see different pictures and how the tumor is really heterogeneous. But even if the tumor looks as serous carcinoma or clear cell carcinoma, I think you can see these two pictures. This is an endometrioid carcinoma. So this is very, very important to be taken into account. And just let me finish with that paper that we published a few years ago. Let me finish with the mixed tumors, because when we have a series of mixed tumors classified with rigorous criteria and microdissect the serous component, microdissect the endometrioid component, and compare the molecular features with that of pure endometrioid carcinomas or pure serous carcinomas, you see that they are really, that in mixed tumors, the endometrioid component is endometrioid and then the serous component is serous. So they exist, they are very interesting tumors, and they should be classified as this. And then we have carcinosarcomas. I'm going to be fast because we will discuss them in the next talk. And we have also neuroendocrine carcinoma. In this WHO classification, they are neuroendocrine carcinomas of the uterus, of the cervix, of the ovary, are put in a different section, but they are tumors of the endometrium. They are similar to undifferentiated carcinomas because they are solid. Sometimes they are mixed with endometrioid carcinomas. Sometimes they have mismatch repair deficiency, but they mimic the most frequent tumors of the lung. For example, this is a typical case. They are sometimes polypoid, as you can see, and the picture is identical with small and large cell carcinomas, neuroendocrine carcinomas of the lung with positivity for neuroendocrine markers. So it's a tumor that is very aggressive and that should be recognized. We have other types of tumors, and just let me discuss with you the two most frequent types. They have been recognized in WHO as emerging entities. One is the gastric type adenocarcinoma, and the second one is the Mesonephric-like adenocarcinoma. The gastric type adenocarcinoma is similar to cervical tumors. In the previous classification, they were put together with mucinous tumors, but they are different. We have the mucinous endometrioid type, and we have the gastric type. They are different. They are similar to the cervical tumors. They have worse prognosis than the mucinous endometrioid tumors with deep myometrium, sometimes with metastasis. And they have prominent borders, desmoplastic reaction. They are similar to the tumors that we see in the stomach or the pancreas, and they should be recognized. They are more frequent in Asia, in Japan, in China, but they are occasionally seen also in Europe and in the States. I don't know really in Pakistan, but probably they occur. They are infrequent. And then we have the Mesonephric-like adenocarcinoma of the endometrium. In the endometrium, there are no mesonephric remnants usually. So that's the reason why we call them Mesonephric-like. And also there are some evidences suggesting that this is just maybe a variant of endometrioid carcinoma with mesonephric differentiation. So this is important. But they are similar to cervical mesonephric carcinoma. In the cervix, there are mesonephric remnants. And it's very important to remember the pattern. You know, when I first saw one case, it was a consultation, and the patient who referred the case to me said, I'm going to send you an endometrial carcinoma that it's very similar to papillary thyroid carcinoma. And I really realized that that was really a good description, because the tumor has a tubular glandular arrangement. There is colloid-like material, papillae, and the nuclei are typical, are very with grooves, similar of papillary thyroid carcinoma, and even the tumor cells are positive for TTF1. And in addition, they are positive for PAX8, for CD10. It's very important to remember this type of tumor because it is associated with visceral metastasis. This is a case in point. Obviously, the tumor is located at the surface, so no associated to mesonephric remnants. We don't have mesonephric remnants in the endometrium. And if we go you see this colloid material, and if we go into higher magnification, you see this groove appearance of the nuclei, scarce chromatin. It resembles really thyroid papillary carcinoma, and in addition, the tumor is positive for TTF1, and the tumor has also KRAS mutation. KRAS mutations are also positive in endometrioid carcinoma. So this is what I wanted to say about the molecular classification. And the molecular classification is important. As you have seen, there are different types of tumors with different morphological features, with precursor lesions, with natural histories, with molecular features. Our pathologic classification allows distinction between low-grade, 70%, and high-grade tumors, 30%. However, we have limitations. We have poor interobserver reproducibility in high-grade carcinomas. We have some histotypes that are heterogeneous regarding prognosis. We will go into that in a few minutes. This is very important for grade 3 endometrioid carcinomas. Not all grade 3 endometrioid carcinomas have bad prognosis, and we cannot recognize the ones that have good and bad prognosis just by morphology. And as I'm going to expand in a few minutes, in the high-grade group, maybe histological typing is not as relevant as in the low-grade group. So these are limitations that should be taken into account. In my opinion, pathologic classification is important, but it has limitations, and that's probably one of the rationale to use molecular classification together with molecular classification. And molecular classification comes from the TCGA study of endometrial carcinoma published in 2013. TCGA, the Cancer Genome Atlas, is a consortium that analyzes the molecular features of different types of tumors. We have the TCGA of endometrial carcinoma, we have the TCGA of high-grade serous carcinoma, we have the TCGA of cervical cancer, we have the TCGA of carcinosarcoma. I'm going to show that to you in the second talk. But that was the TCGA of endometrial carcinoma, and it provided important information. It showed that there were 4 different types of tumors, quite independently of morphology. There is one group of tumor, the blue, it's associated with very good prognosis. It is called the ultramutated type because the tumors have many mutations. And they have many mutations because they have a mutation in a polymerase. It's called POL-E. And that polymerase, it's not working properly. It allows the tumor cells to accumulate mutations. Then we have the bad group of tumor. It's the red one. And you see, this is called the copy number height because they have many copy number variation. They have deletions, they have amplifications. And it's called the Serous-like because this group is enriched with serous carcinoma. And then we have two tumors in between. Tumors with microsatellite instability and the tumors that do not have high mutation index, that do not have high copy number alterations. They are in between. So this is really important. Polymutated tumors are really important. In different series, it has been shown that this is a group of tumor with very good prognosis. And very importantly, this is a tumor that frequently, type of tumor that frequently has high-grade features. It's enriched with high-grade endometrioid carcinoma. So tumors that at the microscope, we think that they are aggressive, but they have very good prognosis. So this is really important. They represent around 10% of endometrial carcinomas. And this is just, I'm going to go into that. That's a cancer cell, a paper in Cancer Cell that we published last year. The reason why they have this good prognosis is because they have such a huge number of mutations, and every mutation is able to create a neoantigen. And a new neoantigen is just a possibility for our immune system to recognize the tumor and react against the tumor. And we demonstrated that in a very nice animal model, but I'm not going to go into details. So polymutated tumor is the tumor that is associated with good prognosis. Serous-like tumors are the tumors that are associated with bad prognosis. They have amplification, they have mutations. Vast majority of serous carcinomas are there, but there is also a subset of endometrioid carcinomas, and obviously mixed tumors, because the mixed tumors have serous component. They have amplifications, deletions, and they have frequently, not always, but very frequently, p53 mutations. So this is the TCGA, but the TCGA is, a classification that is made by molecular analysis. And it's difficult to be brought to clinical practice. But several groups, including ourselves, and basically the two leaders were the group in Vancouver and the group in Leiden, proposed a surrogate, 4 markers, mutation analysis of poly, and 3 immunohistochemical markers, p53 and 2 mismatch repair proteins, MSH6 and PMS2. And by using these 4 markers, we could stratify the tumors in the 4 TCGA subgroups. So if there is a mutation in poly, the tumor is a polymutated endometrial carcinoma. If there is p53 abnormal expression, the tumor is serous-like. If there is abnormal mismatch repair by MSH6, but by PMS2, this is an endometrial carcinoma with microsatellite instability. And if there is any of this alteration, the tumor is an endometrial carcinoma with low copy number alteration, or what the people from the Netherlands says, a tumor with non-specific molecular profile. And this is the paper from the group of Vancouver showing that by using this surrogate, these 4 markers, we could stratify the tumors in 4 prognostically groups. And again, you see that the polymutated tumors have very good prognosis. And very important, now in some countries, there are recommendations to use immunotherapy for tumors having high mutation burden. And the tumors that have higher mutation burden in the endometrium are polymutated tumors and tumors with microsatellite instability. So this molecular classification allows not only prognostic stratification, but also allows classification of the tumors regarding the possibility of using immunotherapy. Polymutated tumors are usually associated with good prognosis, but some are not, a few are not. But for tumors with microsatellite instability, this is, I think, a possibility. For tumors with microsatellite instability that recur, there is the possibility of immunotherapy. The TCGA-based surrogate is not perfect. We have seen that the pathologic classification was not perfect. The molecular classification is not perfect. I don't know in Pakistan, but in Europe, polymutation analysis is not available in the vast majority of pathology labs. So this is important. If we perform polymutation analysis in all endometrial carcinomas, this is probably unaffordable. And not all polymutations are associated with ultramutated status, so we have to be aware. Now there is a paper showing the mutations that are associated with this good prognosis. So we have to be careful. This has not been standardized. So it's important to look for mutations in the exonuclease domain, because not all the mutations are functional. And here you have the mutations that are functional. And in red, you see the mutations that account for almost 70% of the cases. So a conservative approach can be to look for these two mutations. You will miss cases, but you will have information on a significant proportion of the cases. Just to show you that not all polymutated tumors are associated with good prognosis. This is a tumor. The tumor has a mutation in the exonuclease domain, so the place where the mutation should be functional, but this mutation was not functional. And we know that because we perform exon sequencing and the tumor was not associated with a huge number of mutations. There were just a few mutations, and the patient died after one year after surgery. So this is a non-functional polymutation. This is a tumor with microsatellite instability, and it has 6 polymutations, but you know, they were non-functional also. And this is, but the tumor was associated with microsatellite instability. And this is again another non-functioning mutation. So just to be aware that nothing is perfect, that obviously if we perform polymutation analysis, we have to look for the functional mutations. And this is just a recent paper from the group of Memorial showing that even theoretically functional mutations in poly can be seen in tumors that recurred. So this is not perfect, but let me go on the other side. Polymutation analysis is very good, and it's particularly very good in high-grade endometrioid carcinomas. An additional limitation is P53. P53 immunostaining is not perfect because it's very good, but it's not perfect because there is a subset of endometrial and of serous carcinomas that are P53 wild type, and also because P53 immunostaining is not always associated with P53 mutations. But in addition, there are tumors that are heterogeneous. Look to that tumor. This is the same tumor. Part of the tumor is wild type, part of the tumor is P53 abnormal. So this is not perfect, but it's very good. And this is just an example of a serous carcinoma. This is a serous carcinoma. And by immunohistochemistry, by exome sequencing, the tumor was associated with wild-type p53. So nothing is perfect. Molecular classification is good. Pathological classification is good. But they are not perfect. And then we have multiple classifiers. What happens if we have a tumor that has polymutations and p53 mutation? This is an evolving area. It seems that p53 mutation is important wherever it is not associated with polymutation or with microsatellite instability. But still there is room for research here. So molecular classification has limitations. Subsets of tumors in the low copy number group or mismatch repair deficiency have different prognosis. Application to low-grade endometrial carcinomas may be not cost-effective. That's something to be taken into account. Maybe polymutation analysis in low-grade endometrial carcinoma is not informative. Polymutation testing and interpretation needs standardization. p53 is good, but not perfect. Data on clear cell and undifferentiated carcinomas or carcinosarcomas are still immature, and prognosis of multiple classifiers is still an evolving issue. And I have five minutes to finish that talk. It is important to remember that molecular classification is not always important in prognosis. It's important because it may help us in pathologic diagnosis. Remember, p53 is not only important in prognosis. p53 immunostaining can help us in distinguishing low-grade endometrial carcinomas from serous carcinomas with this glandular arrangement, and that's a mistake. And then what I mentioned before, tumors with polymutation, with tumors with mismatch repair deficiency can look like serous carcinomas, but they are, in the vast majority of cases, endometrioid carcinomas. So I think that is important to help us in making the diagnosis. And the final question that I would like to address in these 5 minutes left is the question, is microscopic examination useful in the time of molecular classification of endometrial carcinoma? Obviously, my answer is yes, because we have seen different types of endometrial carcinomas. And now we are going to see if the molecular classification is useful in all types or maybe more useful in specific types of tumors. So this is more or less the types of tumors that we are dealing with. Remember, low-grade, high-grade. We are good in distinguishing low-grade and high-grade from morphology. In the low-grade, in my opinion, it is not really demonstrated that the molecular classification is helpful. Vast majority of tumors are tumors with mismatch repair deficiency or low copy number tumors. May be important in distinguishing the p53 mutated. For the polymutated tumor, probably doesn't add any information. So we can maybe not, we may be not forced to perform polymutation analysis in this setting. And just let me show you an example of a grade 2 endometrial carcinoma that has p53 mutation. So, okay. But, you know, in this particular case, the patient was very good after 5 years of follow-up. And maybe in this setting, in the setting of low-grade endometrial carcinoma, we have other markers, and L1-CAM is one of these markers. So maybe it's in the high-grade arena where the molecular classification is important. And remember that we have poor reproducibility in this 10%. Remember, this is the group in which differential diagnosis between high-grade endometrial carcinoma and serous carcinoma was more difficult. This is probably the scenario in which the molecular classification is more justified. This is the area, high-grade endometrioid carcinoma, and the tumors in which the differential diagnosis between high-grade endometrial carcinoma and serous carcinoma is difficult. And this is an important message of my talk. In this scenario, and this is a paper that we published together with Talin Bosse, with Rob Soslow, Blake Gilks. In this scenario, this is important. And I mentioned to you before, high-grade endometrioid carcinoma is heterogeneous. And with the molecular classification, we capture that heterogeneity. So tumors that are morphologically aggressive can be associated with good prognosis or bad prognosis, depending on the mutational profile. So in this group of tumors, I think molecular classification should be performed, full molecular classification. I am not sure that the molecular classification is important in serous carcinoma, because vast majority of serous carcinoma are tumors with high copy number. We capture there with p53. Performing poly-mutated analysis will allow us to identify mimickers, but vast majority of serous should be tumors with p53 abnormalities. And there is some, I'm going to skip this slide. Is molecular classification useful in the unusual types of tumors? Data is not mature. For clear cell, there are some papers, but data is immature. The same for undifferentiated carcinoma. As I will mention in the next talk, also for carcinosarcoma. Data is not strong. So this is the end of my talk. It's 1 hour, so I am on time. And I will just to give you my conclusions. Pathologic classification is prognostically important. And we have, you know, that's what we do, classifying the tumor at the microscope. And we have to keep doing that. And the new WHO classification provides information regarding that. But it is not perfect. And the molecular classification provides additional information, even can help us in classifying the tumors. And it is particularly important in high-grade endometrioid carcinomas. Conventional pathology may help in selecting endometrial carcinomas for molecular analysis. So maybe polymutation is not required in low-grade endometrioid carcinoma. This is controversial, but at least is my opinion. And the final conclusion, combination of pathological and molecular classification seems to be the most important approach. So thank you very much for your attention. And I'm wondering whether I should go to the next presentation and maybe give the possibility of questions at the end of the second presentation.
Yeah, questions would be at the end of second presentation.
Okay. So I'm going to go to the second talk. It's going to be, I think, shorter, and then we'll have time. Wonderful. So is this okay? Okay. So let's take a breath and let's go to the second issue, which is mixed tumors of the uterus.
Dr. Xavier's screen is not shared.
Is not shared? Okay.
Yeah.
Is that okay?
Yeah, it's okay now.
Okay. So let's go to mixed tumors of the uterus. It's a very interesting issue. I think we're going to discuss several tumors. So this is more or less the tumors that are included in this chapter. We have adenomyoma. We have a lesion that is very interesting, a typical polypoid adenomyoma. We have adenofibroma with a question mark. This is a lesion that is not included in the last WHO classification. So I'm going to be brief on that. We have adenosarcoma. And then we have carcinosarcoma, which is a tumor that we have moved into the endometrial carcinoma category. And then we have, again, carcinofibroma, which is a disease that is not longer considered a type of tumor. So let's go to adenomyoma. Adenomyoma, probably this is a pathology. This is the tumor that is benign. It's a benign tumor composed of a variable number of endometrial glands and endometrial type stroma surrounded by smooth muscle, the latter being most prominent. They may occur intramyometrial, polypoid, but also extrauterine, sometimes in the broad ligament and mimic like an accessory uterus. And these are pictures from the WHO book showing, this mass that is composed of this mixture of smooth muscle and endometrial glands with stroma. I think it's a lesion that has nobody has problems in identifying, but it's worth to remember that it exists. More tricky is sometimes the tumor that is called endocervical type adenomyoma. This is a tumor that is polypoid or intramural. The epithelial glands are endocervical type in a lobular arrangement, and the stroma is abundant with smooth muscle. Metaplasias are common, and the main problem is that since this is sometimes found deep in the cervix, people is sometimes concerned on the diagnosis of adenoma malignum. And this is a case in point. That case was sent to me a couple of years ago with the concern of adenoma malignum, and you see the glands are indolent, and also the stroma is composed of smooth muscle, and this is just a benign lesion, but it's worth to remember that the lesion exists and that can cause troubles in differential diagnosis. This is a funny tumor, a typical polypoid adenomyoma. And this is a lesion. It's usually a polypoid lesion in a quite young patient. It's composed of glands showing cytologic atypia and usually architectural complexity set in a fibromuscular stroma. That word fibromuscular is interesting, and I will go into that in a few minutes. It's usually seen in patients that are young, and the lesion is usually in the lower part of the endometrial cavity. This is an example. You see this specimen. Obviously, there is a huge leiomyoma, but you see the polyp, and the polyp is in the lower part of the uterine cavity. And this is low power view. I think this is a tumor that is more or less easily to be recognized at low magnification, because at low magnification, you see this organized pattern with glands and stroma. The glands, which may be a little bit crowded. In the lower picture, you see squamous differentiation and even comedotype necrosis. That's very frequent and it's worrisome, but no problem. This is commonly seen in that lesion. Sometimes you see the squamous differentiation in the lower picture, and the complexity in the higher, at the top, the picture at the top. There is complexity. The glands show back-to-back arrangement. So that can be worrisome in a small biopsy. Again, you see that complexity. Again, squamous differentiation. And whenever we perform Mason stain or cytokeratin stain or actin stain, we see this biphasic pattern. This is a case I saw several months ago. It was really very, very worrisome. Again, the biphasic pattern. And this is more or less a summary. It's a lesion that is seen in premenopausal patient in low uterine segment with atypical glands, squamous metaplasia with discomedo-necrosis, and this fibromuscular stroma. And many years ago, Terry Longacre proposed to change the name for atypical polypoid adenomyofibromas just because of the morphology of this smooth muscle tissue, and also proposed to use two terms, atypical polypoid adenomyofibroma and atypical polypoid adenofibroma of low malignant potential. So this proposal did not succeed, but the idea is interesting because this is a lesion that can progress to carcinoma, and it's important to be taken into account. Because when the tumor has complexity, even there is adjacent endometrial hyperplasia, you can have recurrence and you can have even endometrial carcinoma. So this is important. Whenever we have an atypical polypoid adenomyoma, we have to be a little bit cautious. And this is an endometrial carcinoma that I saw at the vicinity of a polypoid atypical adenomyoma, and you see the complexity of the glands. And this is an example in which the atypical complex hyperplasia was seen at the vicinity of a typical polypoid adenomyoma. So there is a progression from a typical polypoid adenomyoma to malignant transformation. Is not frequent. It's calculated in 8% of the cases. But remember, the risk of recurrence is 30%. We should be aware of this. And this is a paper that we published many years ago showing that indeed some atypical polypoid adenomyomas have molecular features similar to endometrial carcinoma. So that explains that this is a lesion that can progress to carcinoma. And our results were confirmed later on in that paper from the Czech Republic, from Pavel Thunder. Yet there are some data, recent data that is interesting. So we can use immunohistochemistry, particularly when distinguishing the atypical polypoid adenomyoma from myoinvasive endometrial carcinoma with squamous differentiation in small biopsies, because this is a problem. Cal-Desmon is important. Cal-Desmon is positive in the myometrium, but is negative in this fibromuscular tissue of atypical polypoid adenomyoma. So this is important. P16 is also important in this differential. And SUBTYPES has been also shown to be expressed in the epithelial and mesenchymal component of a typical polypoid adenomyoma. So whenever you are not sure and you have a small biopsy, you can have these markers, and that will help. And then there is this lesion, diffuse leiomyomatosis involving the endometrium, which is also sometimes in this differential diagnosis. This is an example. This is a small biopsy, and all over the biopsy you see smooth muscle that is, highlighted by this actin stain. This is not a typical polypoid adenomyoma. This is the presence of many leiomyomas in the uterus and also in the endometrium. But this is just a mimic of this disorder. So that is what I wanted to say regarding a typical polypoid adenomyoma. And then we will go into this field, controversial field of adenofibroma and adenosarcoma. As I mentioned before, the category of adenofibroma has been deleted in the last category, in the last edition of the WHO book, the one that was published 1 month ago. So that was the definition of adenofibroma in the previous WHO classification, a tumor composed of an admixture of Mullerian epithelium and stroma, both components being benign. The stroma is derived from endometrial stroma, which it may resemble, but it's more often fibroblastic. But this category has been deleted in WHO 2020. So adenofibromas are just very similar to polyps, because whenever you have the morphological features of adenosarcomas, regardless of the presence of mitosis, chances are that this is going to be an adenosarcoma. So adenosarcoma has that definition. It's a distinctive uterine neoplasm characterized by benign, occasionally atypical epithelial component and malignant low-grade stromal component. This is a low-grade sarcoma. It's unusual. It occurs at any age, but sometimes 40% occurring below 50 years of age. I have seen many examples in young premenopausal patients, and we have to be aware that this is a low-grade sarcoma, so it can be treated conservative, but with caution, because I have seen patients dying of adenosarcoma because of too conservative management. So the initial presentation is vaginal bleeding, and the tumor may occur in cervix or in the uterus. It occurs in the uterine cervix in younger patients. It is a polypoid mass occupying the uterine cavity, should be large, more than 3 centimeters. I'm going to go into that in a few minutes. Myometrial invasion is seen in 15% of the cases. The morphology, the tumor resembles phylloides tumor of the breast. You can have metaplastic changes in the epithelial component, and the stroma has this typical periglandular cuffing. And mitosis should be seen in the stromal component, but they may be scarce or even absent. So that's the problem in distinguishing Mullerian adenosarcomas from adenofibroma. There is one series in which tumors fulfilling the morphology, there are a few cases of tumors fulfilling the criteria of adenosarcoma but without mitosis, and they behave as adenosarcoma. So that was one of the reasons of deleting the category of adenofibroma. This is the typical morphology. A cauliflower type of tumor, fleshy, with this cystic component. This is quite typical and big, large. This is low-grade morphology, and you can see at this low-grade the cuffing, the periglandular cuffing. This is very typical. The phylloidal appearance of the glands, and this condensation of the stroma around the glands. Sometimes this cauliflower-like projection into the glands, and this concentration of the stroma around these dilated, irregular shaped glands. This is quite typical. You see concentration of the stroma. Again, you can have these many metaplastic changes, and obviously we have to look to the stroma. By the way, you see that sometimes the glands are ciliated, many metaplastic changes, and you see mitosis. Mitosis are helpful, but they are sometimes scarce. You see mitosis here, but even in the absence of mitosis, the stroma is cellular. This is not normal stroma. And sometimes we have heterologous elements. We can have benign appearing smooth muscle. We can have multinucleated giant cells. We can have rhabdomyoblast, chondroid tissue, adipose tissue, or even sex cord elements. The most important finding is to rule out the presence of sarcomatous overgrowth. That means overgrowth of the stromal component in the absence of glands. This is important, is seen in 25% of the cases, and this is associated with bad prognosis. So this is really important. The presence of sarcomatous overgrowth predicts bad prognosis. And you see, this is an area of sarcomatous overgrowth in an otherwise typical low-grade adenosarcoma. And in that patient, this component was also responsible for metastasis. So this is really important. This is a high-grade component. The tumor is not longer a low-grade sarcoma. This is another example. In that case, the patient, the lesion was removed after chemotherapy, and you see the atypicality of the component, the absence of glands, and the presence of rhabdomyoblast. So this is heterologous elements here. So that should be taken into consideration. And the question of mitosis. Mitosis are helpful, but there are cases without significant mitotic activity that have recurred or metastasized. So it is the morphological features that allows us to make the diagnosis of Müllerian adenosarcoma. Recurrences occur in 20–30% of the cases, usually confined to vagina or pelvis. The tumor is sometimes associated with lymph node metastasis. This is infrequent, but they are associated with bad prognosis, and that's the reason for which some people suggest performing lymphadenectomy. I'm not really convinced of that. Recurrences contain only stromal elements because this is a sarcoma. And myometrial invasion and sarcomatous overgrowth are the two indicators. And this is a paper emphasizing the importance of lymph node metastases, which are unusual, but I have seen examples, and also how the presence of lymph node metastases, sarcomatous overgrowth, deep myometrial invasion, or heterologous elements, each of these is associated with bad prognosis. Just a few comments regarding molecular pathology because that can help. And let me just go into that. This is a paper by Carlos Parra Herrán, now in Brigham and Women Hospital. And he showed that p53 may also be helpful in identifying Müllerian adenosarcomas that may be associated with bad prognosis. In fact, when he analyzed his series, p53 was frequently expressed, was frequently abnormal in the tumors with sarcomatous overgrowth, but also in tumors without sarcomatous overgrowth that recurred. So that can be used. It's not 100% reliable, but it can help. Obviously, Müllerian adenosarcoma has a specific staging, very similar to endometrial carcinoma. And just let me just interrupt a little bit the session, just to show you a challenging case. Just obviously we cannot interact, but just in your place, try to make the diagnosis. This is a woman, 41 years of age. I got that polyp in the endocervical isthmic junction in consultation. That was a big polyp. And you see the polyp has two components. One at the right, more phylloides. The second at left is, you know, the lesion does not contain glands. So this is the adenosarcomatous component, the phylloides appearance, the dense stroma. I think I am convincing you that this is adenosarcoma. This is the second component, strange, with cord arrangement, some vacuolated cells. But the way these lipid rich cells are quite typical of this situation, very typical of this situation. And this is the two components merging. Probably you raised the right diagnosis. The second component is a sex cord-like component. This is alpha inhibin. This is calretinin. And this is sex cord-like component in Mullerian adenosarcomas. So something to be taken into account, because this is sometimes funny. It's infrequent, but it's, the important thing is that the significance is a little bit different from that of sarcomatous overgrowth. And to the best of our knowledge now, the vast majority of the patients, the sex cord component had indolent behavior, but it's something to be taken into account. So the differential diagnosis is with adenofibroma. This no longer exists, sometimes with polyps, with atypical polypoid adenomyoma, with endometrial stromal sarcoma, but in endometrial stromal sarcoma, there is not the biphasic pattern. Embryonal rhabdomyosarcoma is an important differential diagnosis, and with carcinosarcoma. So endometrial polyps sometimes raise the differential diagnosis with adenosarcoma, particularly in patients that have received tamoxifen, because the polyps in tamoxifen-treated patients are usually large polyps with hypercellular stroma, different types of epithelial metaplasia, Stackhorn glands. So they are similar, but they are quite characteristic. It's this huge lesion, it's very typical. And the morphology doesn't fit exactly. There is no condensation of the stroma. The changes are difficult. Just to be sure that obviously you are aware that whenever you have tamoxifen polyp, you have to sample the specimen. This is one case in which we found this tiny focus here of metastatic breast carcinoma that could be overlooked. Is sampling would not be so extensive. But I think that tamoxifen polyps are different. There are polyps that have bizarre stromal cells. So whenever we have that, we have to rule out the possibility of adenosarcoma. But there are other features. There is the condensation, there is the phylloidal arrangement. So I think it's different. And this is a very nice paper of Marisa Nucci, Brooke Howitt, Bradley Quaid, showing the differential diagnosis between Mullerian adenosarcoma and a series of polyps with some features. And I think this is an important table. Look, size is important. If you are in front of a polyp in which you are doubting between polyp and Mullerian adenosarcoma, size could be an indicator. Obviously, the phylloides-like architecture should be well developed. And obviously, the presence of stromal atypia, condensation, should be diffuse in the lesion. So, but some cases are really tricky. This is an important differential diagnosis. embryonal rhabdomyosarcoma. Remember, it occurs in vagina, in children, this is typical, but it occurs also in the cervix and in adults. And it is a polypoid tumor. And there is subepithelial condensation of cells, so the so-called cambium layer, and that can be similar to the concentration that we saw in adenosarcoma. There are small, round, or spindle cells, and obviously there is skeletal muscle differentiation in cartilage, but we have seen that adenosarcoma has also heterologous elements. So that can be tricky, and in my experience, it's easy to misinterpret an embryonal rhabdomyosarcoma as an adenosarcoma. And this is important because adenosarcoma is low grade. Embryonal rhabdomyosarcoma is it's more aggressive. So this is an example. This case was misinterpreted as an adenosarcoma. And you see it has this polypoid arrangement, not really phylloides-like, but if we go to higher magnification, you see this concentration of stroma in the subepithelial areas, quite similar. But if you see, quite similar. But when we go, we start seeing cells, you see cells with abundant red eosinophilic cytoplasm, indicating skeletal muscle differentiation. And when we perform myogenin, there is universal positivity almost for myogenin. And I think these are the clues. The embryonal rhabdomyosarcoma has this grape-like morphology. I think this is very important. Alternating cellularity, edematous and cellular areas. The stromal cells are more primitive. The lesion, the embryonal rhabdomyosarcoma, is more frequently associated with cartilage. And the relationship between the stroma and the glands are different. It's not phylloides-like, but it's just invaginations rather than two components. Just to finish adenosarcomas with mentioning that the tumor can be seen also in the ovary. I just saw last week an example of ovarian adenosarcoma with sarcomatous overgrowth. The diagnosis was very difficult because the tumor looked as a sarcoma, but in small area of the ovary, there was this Müllerian adenosarcoma typical component that allowed us to make the diagnosis. So it's important to remember that Müllerian adenosarcoma, even with sarcomatous overgrowth, can occur in the ovary, and it has worse prognosis in relation with age, tumor rupture, high-grade stroma, and sarcomatous overgrowth. So this is what I wanted to say about adenosarcoma, very important entity. And now we will end the talk. We will use, I think, 15 minutes to talk about carcinosarcoma. Carcinosarcoma was formerly included in this group of mixed tumors of the uterus, but now it has been moved to endometrial carcinoma, and I am proud to I was the one who proposed that. In fact, I proposed that in the previous classification, but it was not approved, but now it was obviously approved. It is a very aggressive form of endometrial carcinoma. But in terms of education, I think it's good to discuss them in the mixed groups of the uterus, mixed tumors of the uterus. So carcinosarcoma is a neoplasm composed of a mixture of malignant epithelial and mesenchymal component. In WHO 2020, recognized as a variant of endometrial carcinoma. Sometimes mentioning with, you know, MMMT, malignant mixed Mullerian tumor. I think that carcinosarcoma is a much better term. It's infrequent, typically in elderly patients. Risk factors are similar to endometrial carcinoma, sometimes with a previous history of irradiation. I have seen many, not, but I have seen several cases of carcinosarcoma in the uterus of patients previously treated with radiation for cervical cancer. So this is something to be taken into account. The initial presentation is vaginal bleeding, and 30% have uterine spread at the time of diagnosis. They are large polypoid necrotic masses, frequently with myometrial invasion. There is the typical biphasic pattern. Epithelial components may be variable. It's very frequently serous, sometimes endometrioid, sometimes squamous, sometimes mucinous, frequently undifferentiated. Sometimes it's difficult to classify the epithelial components. The mesenchymal elements can be homologous or heterologous. Rhabdo elements are frequent, chondro, lipo, osteo, and sometimes the tumor has neuroectodermal differentiation, so raising the differential diagnosis with PNET. So this is the typical gross appearance. I think that all of you have experience. It's a very aesthetic tumor with this polypoid growth, with necrosis, sometimes protruding through the cervical os. Again, I like to take pictures of carcinosarcomas. Again. And the biphasic pattern. These glands, frequently with serous-like features. You see this papillary arrangement. You see, serous appearance. You know, highly atypical cells with prominent pleomorphism. Very typical of serous carcinoma. It's quite frequent. Sometimes that's nice picture because when I saw that case, in that particularly picture, the resident that was seeing the case with me thought that that was an adenosarcoma because that it has a little bit of phylloidian pattern. This is occasionally seen in carcinosarcoma, but this is obviously not adenosarcoma, it's carcinosarcoma. The glandular elements can be poorly differentiated, as you see. Again, the biphasic pattern. This biphasic pattern, I think that you can see in the stroma some cells that start having abundant eosinophilic cytoplasm. Although the component is, at least in my experience, more frequently serous, sometimes you see endometrioid morphology. And here you have squamous differentiation in the center and some endometrioid appearance. And sometimes it's mixed. So everything is possible. Here you have the component, the two components, and you start seeing the rhabdomyosarcomatous component, which starts to be more obvious here. This is out of focus, sorry. This is again, you know, squamous elements. So remember that everything is possible, and some tumors have this endometrioid appearance, and sometimes there are some components that are just difficult to recognize as epithelial or mesenchymal, and there is this central necrosis in many areas. Hyaline globules, that's something that occurs if you see a poorly differentiated tumor and you see hyaline globules. Well, that can be an indirect indicator of carcinosarcoma. Again, high-grade component and cells that shows this skeletal muscle appearance. High-grade sarcoma component, as you can see here. And here you see more or less cartilage, that you can have cartilage, you can have liposarcoma, you can have different, this is cartilage in a carcinosarcoma. And very important, myometrial invasion. That's going to be very important in terms of prognosis. If a carcinosarcoma has chances to survive, is because the tumor is superficial or because the tumor has a molecular feature that we will go into that in a few minutes. So just again, let's make a break and I'm going to show you one case. This is a 71-year-old woman. The patient has a pelvic mass with peritoneal involvement. In another hospital, there was a peritoneal biopsy, and the biopsy was interpreted as a pinette because there was this arrangement. Really, the glands, the tissue had a neural pattern, and the tumor cells were positive for glial fibroacid protein and also synaptophysin. And in fact, you know, we have primitive neuroectodermal tumors in the female genital tract. Just to remember that, well, they exist, so that was a possibility. But in this case, after the initial biopsy of pinette, the patient was referred to our hospital, and an ovarian tumor was detected, and there was an anexectomy and removal of peritoneal metastasis after chemotherapy was given to the patient. And this is the uterus with the ovary. You see the ovarian mass. And in the ovarian mass, in fact, there was this appearance with this loose stroma and some cells really that looked neuroectodermal. Really, the tumor has some resemblance to the neuroblastomas that we see in the adrenal gland. And again, the tumor was positive for synaptophysin, for glial fibrillary acid protein, also positive for WT1, but the tumor has also other components. The tumor had also cartilage and obvious epithelial components. So that was not pinette, but a carcinosarcoma with a neuroectodermal differentiation. So something that you should that should be kept in mind. And this is unusual, but that has been referred in the literature several times. So from the immunohistochemical viewpoint, the epithelial components are positive for keratins, but in EMA, but also vimentin, and the mesenchymal. So anything can be possible. The diagnosis is, I think, based on morphology. The differential diagnosis is broad. Obviously, we have high-grade endometrioid carcinoma, but obviously, in carcinosarcoma, we see a biphasic pattern. I mentioned before the dedifferentiated carcinoma. Before the description by the people in MD Anderson of dedifferentiated carcinoma as a tumor composed by a low-grade endometrioid carcinoma and an undifferentiated component, I'm sure that dedifferentiated carcinomas were classified as carcinosarcomas, but now we have different criteria. Sometimes endometrioid carcinomas have metaplastic changes, and this is not carcinosarcoma. This is an area of bone metaplasia in the setting of a conventional low-grade endometrial carcinoma. And in that, the patient is alive and well 15 years after removal of the lesion. So this is not carcinosarcoma. And this is the tumor that I mentioned before in the previous talk, endometrial carcinomas of the endometrium with sex cord-like formation and hyalinization, because this has also a biphasic pattern. And you know, when you see that, you can have the temptation of calling that carcinosarcoma. The epithelial component is low grade also. This is a tumor that is associated with, this is the description, initial description by Dr. Yang, as a tumor that may be confused with carcinosarcoma. And this is a tumor that is usually associated with beta-catenin nuclear expression, which is very unusual in carcinosarcoma. So this is really helpful in this differential diagnosis. We have discussed adenosarcoma in extents. Undifferentiated sarcoma. So now sarcoma is now an evolving field. We have different types of sarcoma, low grade, high grade. Obviously, this is not the topic to be discussed today. We have undifferentiated sarcomas, very high grade tumors. And whenever I have an undifferentiated sarcomas, I always try to rule out that this is a sarcoma overgrowth in an adenosarcoma or a sarcoma overgrowth in a carcinosarcoma. And I have to say that, you know, in some cases I found the second component. So it's important to rule out this possibility also. The prognosis is poor. Carcinosarcoma is a very aggressive type of endometrial carcinoma. For stage 1, the prognosis is much better. And adverse prognostic factors are lymphovascular space invasion, deep myometrial invasion, grade, histological subtype, and the presence of heterologous element. This is a paper by Ruba Ali Femi showing the prognostic importance of tumor size, myometrial invasion, histological subtype, presence of rhabdomyoblastic differentiation, and lymphovascular space invasion. So I think that these features should be taken into account when reporting this sort of tumor. And these are the multivariate Cox regression analysis of these parameters. So the pattern of metastasis, the pattern of dissemination is similar to serous carcinoma. So the tumor is spread into the omentum. It goes to the lungs through the vessels. Epithelial elements prevail in metastasis because this is an epithelial tumor. But a biphasic pattern is seen sometimes in distant metastasis. The staging is similar to is the one of endometrial carcinoma. And we have also obviously carcinosarcomas in the ovary. In this case, they are frequently arising from high-grade serous carcinoma, but also from endometrioid carcinomas. And also we have carcinosarcomas in the cervix, and you know sometimes they are difficult to be diagnosed. And just let me finish with the molecular features, which are, I think, interesting. And it's going to take 5 minutes at most. So there are many molecular features, and molecular features have been, you know, interesting to recognize that tumor really as an epithelial tumor. It's called the conversion theory. There are many molecular tools that have demonstrated that the carcinosarcoma, the driver is the epithelial component. For example, this is one case that I saw many years ago when I worked in Barcelona with Dr. Prat. This is a serous ovarian, high-grade ovarian cancer that recur in the Douglas pouch and recur as a carcinosarcoma. There was a serous carcinoma and then a recurrent carcinosarcoma. And both tumors had exactly the same p53 mutation. So it's now clear that the uterine carcinosarcoma, like sarcomatoid or metaplastic carcinomas of other organs, we have similar tumors in the breast, in the kidney, in the urinary bladder, in the larynx, are carcinomas, in which a sarcomatous element arises. So, and this is what is called an example of epithelial mesenchymal transition. So we have different types of carcinomas, but any type of carcinoma can give rise to carcinosarcoma just when one component of the tumor expresses what is called epithelial to mesenchymal transition. What is epithelial to mesenchymal transition? It's something that is produced during embryologic development. During embryologic development, epithelial cells are transiently transformed into mesenchymal to expand the organ. So the cells know that. Endometrial carcinoma uses epithelial to mesenchymal transition, uses that at the invasive front. When we analyze the invasive front of traditional normal endometrial carcinoma, you see features of epithelial mesenchymal transition. But this is transient. In endometrial carcinoma, epithelial to mesenchymal transition is transient to allow myometrial invasion. And that happens frequently in endometrial carcinoma. But what happens in carcinosarcoma is that this epithelial to mesenchymal transition is not transient, is permanent. And cells acquire permanently this mesenchymal morphology. And that's the reason. And this is a study that we performed many years ago, and we realized that frequently carcinosarcomas have not only markers of epithelial to mesenchymal features, but almost always evidence of skeletal muscle differentiation. Maybe this is not obvious at the microscope, but molecularly this is present. And we demonstrated that many years ago by demonstrating the presence of microRNA signature of epithelial to mesenchymal transition in carcinosarcomas. So before I had mentioned the TCGA of endometrial carcinoma, and a few years ago we had also the TCGA of uterine carcinosarcoma. And I'm gonna go fast into that. What the TCGA confirms is that carcinosarcoma is a tumor very frequently associated with p53 mutations, like serous carcinoma, very frequently associated. And like in our series of cases, they show that carcinosarcoma has epithelial to mesenchymal transition. And as I mentioned, I hope I have convinced you that this is the basis for this development of these mesenchymal elements. And okay, these are papers. The question, and I'm going to finish with that, is whether we can apply also in carcinosarcoma the TCGA surrogate approach that in the first talk I have proposed for endometrial carcinoma. And the question is that maybe that we don't have too much information, but the important message, so this is the surrogate that I have showed to you before. Maybe it can be interesting is if you perform the surrogate that I have presented to you before to carcinosarcomas, you are going to see that the vast majority, obviously, are p53 abnormal. Few cases are associated with microsatellite instability, but very importantly, there are very small percentage of polymutated tumors. And we have seen that polymutated tumors are associated with good prognosis in traditional endometrial carcinomas. Are they also associated with good prognosis in carcinosarcomas? This is a case in point from me. Look, this is a case that was surgically removed. The tumor was surgically removed in 2009. Very invasive tumor. Patients, the tumor was mutated for poly. Patients is well without disease after more of 10 years. And this has been also reported in the literature. So this is a message. Maybe polymutation analysis is also important in this tumor. And this is the end of the two talks. And in this second talk, I have addressed the issue of mixed tumors of the uterus. So thank you very much again for your attention. Has been long. I hope that you have liked this, the whole picture of uterine tumors. Thank you very much.
Thank you very much, Dr. Xavier. And these are magnificent talks and very informative for all the pathologists in Pakistan. And now you have a few questions. Okay, first question is from Dr. Usman Hassan. So sometimes there is a problem in differentiating between endometrial grade 3 endometrioid adenocarcinoma and serous carcinoma based on histology and immunohistochemistry. Both can show diffuse P16 and P53 expression. MSI status might not be helpful in every case. What should be the approach if genetics is not available?
So, yeah, there is a small percentage of cases in which this is very difficult. Obviously, if P16 is not informative, if microsatellite instability is not informative, sampling is maybe informative. So look for evidence of serous or endometrioid differentiation in any part of the tumor. This is helpful. Age is important. So if you have a serous carcinoma in a patient younger than 60, this is not the most frequent scenario. But I agree with you that in some cases, this is difficult. But let me tell you something. In this scenario, maybe there are some papers showing that if the tumor is P53 abnormal, the prognosis is not that different between high-grade endometrioid carcinoma and serous carcinoma. So this is probably an academic difference. So sometimes the diagnosis that I wrote is high-grade carcinoma, P53 abnormal, and maybe in a comment I favor one on the other possibility if the diagnosis is really difficult.
Okay, another question from Dr. Usman Hassan. Is there any immunohistochemical marker available for pole mutation?
No.
What should be the minimum cost-effective gene panel available at molecular lab, which covers most of the pole mutations?
Well, the problem is that, polymutation is just, you can do that by next generation sequencing. I don't know how next generation sequencing is available in Pakistan. In Spain is available in very central places, in big hospitals like the one in which I work, but not in small hospitals in which endometrial carcinoma is frequent. It's also performed by Sanger sequencing, but we don't have an immunohistochemical marker. So what I think is that the best way is to restrict, if you don't have resources, which is the usual way, at least in Europe, maybe the good way is to restrict polymutation analysis just for high-grade endometrioid carcinomas, in which, in my opinion, this is really, really cost-effective. and try to gather cases in centers in which Sanger sequencing is, or next generation sequencing is available.
Okay, another question before the time lapse. So can focal periglandular tumor condensation qualifies as adenosarcoma, especially in extrauterine locations?
Yeah, this is one of the findings that you can look for. Obviously, adenosarcoma can occur outside the uterus. We have seen in the ovary, but also in the peritoneum. And you have to look for the whole picture that I described. And obviously, look for sarcomatous overgrowth, because adenosarcoma is a low-grade sarcoma. So sarcomatous overgrowth is really the important finding.
Okay. Another question from Dr. Sajid Mushtaq. What is your opinion of P10 IHC?
For me, it's, I mean, I'm using that. In fact, you know, this is an immunohistochemical technique that is difficult. But many years ago, we published that in human pathology. We optimized the antibody. In my hands, it works perfectly. I use sometimes that in hyperplasias because it helps me, not because I made the diagnosis of hyperplasia because of the lack of staining, but it helps me in assessing the clonal appearance of the lesion. And in the diagnosis of endometrial carcinoma, if you have a tumor that has negative expression of P10, for sure, this is endometrioid carcinoma. Let me tell you something. I have some serous carcinomas with decreased expression of P10. And when I sampled the tumors, they were mixed endometrioid serous carcinoma. So whenever I have a serous carcinoma with the decreased expression of P10, chances are that this is the serous component of a mixed serous endometrioid carcinoma. So I think it's very useful, but I understand that this is tricky immunohistochemistry.
Okay, thank you very much. I think now it's time is up, and we are very thankful to you. And there are a few more questions, and I think I will send you in the form of email.
Okay, perfect.
Yeah. Thank you very much, Dr. Xavier.
Thank you. Has been really a pleasure.
Okay, thank you very much.
Bye.
Okay, the next 1 hour is a break, and this is our lunchtime. And do join us again at 3 o'clock. Thank you very much. Okay, I welcome all the participants again in the second session of today's workshop. All of you must have a, I think, very heavy lunch since this is a long session. First of all, we are deeply honored since time is not very civilized in US right now. It must be 5 in the morning, and Dr. Parwani is kind enough to deliver his talk at this time. In this session, we have 2 lectures and 1 slide seminar. First lecture is of Dr. Anil Parwani, who is professor of pathology at the Ohio State University. He serves as the vice chair and director of anatomical pathology, pathology informatics, and director of digital pathology. Moreover, he has expertise in biobank informatics, clinical and research data integration, application of whole slide imaging, and telepathology. His research is focused on diagnostic and prognostic markers in bladder and prostate pathology and molecular classification of renal cell carcinoma. Dr. Parwani has authored over 300 peer-reviewed articles. He is editor-in-chief of Diagnostic Pathology and one of the editors of Journal of Pathology Informatics. The topic of his today's talk is Advancing Cancer Diagnostics, Application of Digital Pathology and Artificial Intelligence. Now over to Dr. Anil.
Okay, so today I'm going to talk to you about advancing cancer diagnostics and applications of digital pathology and artificial intelligence. So I'm excited to be here, and I will today focus on, so I'm speaking from Columbus, Ohio. So this is some pictures of Columbus, Ohio. This is the campus where the medical center is, and the hospital is right here in this complex. So today I'd like to provide you with an overview of digital pathology and AI and its current state for clinical diagnostics. I'd like to provide you with an understanding of the challenges and opportunities for implementing digital pathology in the clinical areas and explore the future directions of artificial intelligence technology and its role in advanced diagnostics. So there are several challenges in pathology today. Pathology is evolving to address them, but not at the pace to keep up with all the new technologies. And it's an exciting time to be in pathology because we are poised for innovations which may be disruptive. So I'm going to try to touch on some of these innovations for you today. So there are several new tools for advanced diagnostics. These include whole slide imaging, genomics, next-gen sequencing, image analysis, and artificial intelligence. In terms of some challenges and opportunities in clinical diagnostics, so we are in the middle of a pandemic. There are new models of healthcare. There is a focus on expense reduction, improving the quality of care. Price of technology overall is going down, and the capabilities continue to improve. And as physicians, we are becoming increasingly comfortable with some of these new modalities. Some of the barriers we face are reimbursement, licensure, regulatory issues. There are still a lot of manual processes in pathology, and there are some unique infrastructure needs if you want to implement some of these new technologies. So let's talk about some of the challenges and barriers. That includes workflow issues. So if you look at the state of anatomical pathology today, there are still a lot of steps from patient bedside, from the time the patient comes to the hospital and all the way to making a diagnosis. There are still a lot of manual steps in place. And there are many handoffs in a pathology specimen life cycle, all the way from accessioning, grossing, processing, case assembly, and signing the case out. And there are also points of potential error, but there are also opportunities to interact and track. So when we implement a workflow, we want to make sure that all these steps are taken in care. There's also working with multiple systems. There are IT challenges. There are issues with integration of data from disparate systems. There's also, when you try to integrate data from multiple systems, that can lead to problems. When I am going to show you some of the workflows that we've built here, some of the key things to look at are interfaces between your lab information system and your electronic medical record, into interfaces between the instruments in the lab. There are also workforce issues. So the demand for lab services, demand for pathology is increasing. We have population growth. We have an increase in population age at 65 or older, and there are expanding molecular and esoteric tests. So there is a shortage of pathologists all over the world, and it's getting to a critical level. So if you look at some countries in Africa and Asia, this shows you the global pathology demand and patients per pathologist by country. So there is a need for pathologists and pathology diagnosis all over the world. And I'm sure this is not unique to, this is the same in Pakistan as well. In the US, the pathologist supply is down relative to diagnostic demands. And if you look at the data from 2007 to 2017, there is an overall decrease in number by 17%, in spite of a corresponding 41% rise in diagnostic workload per pathologist. There is an 18% increase in pathologist positions in terms of residency match, but number of positions filled by seniors from the US medical schools during this time has decreased from 64 to 40%. So if you ask medical students why they don't want to go into pathology, some of them think pathology is invisible. Pathologists are not directly working with patients. There's also technology adoption issues. So if you ask pathologists, like, for example, digital pathology, why don't you want to use a digital scanner instead of a microscope? Pathologists do not completely trust digital pathology systems. They're afraid to give up their microscopes. There are regulatory hurdles which have dampened adoption, and the financial gains are not clearly defined. So if you were to look at your workflow in your lab, in your hospital, and you want to convert your workflow to a digital workflow, there are financial issues, there are regulatory hurdles which have dampened adoption. So if you look at just overall the adoption curve, most of the labs and hospitals are in very, very early in adoption of digital pathology. This is where we started about 3 years ago, but now more than half of the pathologists are signing out digitally. So there have been improvements in the technology, and pathologists are coming around. They are getting more and more comfortable, but they are also afraid to give up their microscopes because some of the things that you can do with a microscope cannot be easily done on digital slides. So during COVID-19, we saw an increase in adoption because pathologists were quarantined or they had to work from home. So during COVID-19, we actually saw more pathologists sign out digitally and remotely than ever before. There's also workload issues, right? So as pathologists, we are qualitatively reviewing each cancer case. It requires an efficient throughput system. It requires an increased ability to communicate inside and outside the institution. Cancer care is becoming more complex, and there is opportunities to collaborate between different disciplines, like in tumor boards and clinical conferences. So we're spending more time, and our reports are becoming more complex. So this shows you a synoptic report, a CAP work list, where most of this data is actually coming from the pathologist's review of the case, including gross and microscopic findings. So these are common data elements from a pathology report. And you can see majority of these are making their way from the pathologist's review of the case. If you look at the WHO books, there is an explosion of knowledge. If you compare the second edition, which came out in 2000, of the tumors of nervous system, to the fourth edition, it's almost 30% more, and a lot of information and a lot of the diagnoses are based on molecular and genomic findings. So there is an explosion of information, and as diagnosticians, we are incorporating all this information in our reports. Patients are demanding more information, right? So they want to know, what do I have? How bad is it? Will I die from it? What are my treatment options? What comes next? So the patients are more empowered. They're reaching out to the pathologists. They're reaching out to the clinicians. They want to know, what is my stage? So the information about cancer, about the diseases, is more easily available to them on Google and internet. So there is more pressure to give the diagnosis faster and better. So how do these new technologies help us overcome some of these challenges? So it's really a very exciting time to be in pathology today, right? So we have options of disruptions. So I view digital pathology as a disruption. I view artificial intelligence as a disruption. And if you look at what we do today in traditional pathology, we have two choices. We have two pathways. We can continue to do what we are doing. So if you read this book, this is the innovator's dilemma. So in this book, the author talks about the difficult choice an established company faces when they must choose between holding on to an existing market for the same thing a little better or enter new markets. So pathology is really all about disruption and it's ready for a disruption. So we can continue to satisfy and do the things that we're doing and only make incremental changes and incremental improvements. Or we can look at different way of doing things that initially does not make sense, does not meet the needs, but you're preparing for the future. So today we have a lot of new tools and technologies. These include several types of microscopes. Many pathologists have microscopes with a digital camera, but now we have whole slide scanners which can scan, or which are high throughput robots, and you can scan up to 1,000 slides. You can load this machine with up to 1,000 slides, press a button, and you can come back and you have digitized slides ready to be viewed. Some of these tissue sections, so for example, in prostate cancer, I'm a GU pathologist. I'm looking at prostate needle biopsies. With this resolution, 0.25 microns per pixel, I can look at a nucleus within a cancer gland, and I can distinguish two nucleoli. So the quality of the image is that good. So some of these new scanners can scan up to 100 slides per hour, 2,000 slides per day at 40x resolution. So it's really come a long way. The industry has come a long way. Two systems were approved by the FDA in the United States. Philips was approved in 2017, and Leica was approved in 2019. Overall, if you look at this technology, which is whole slide imaging, we've seen more than a decade of evolution. Overall, the cost to make a glass slide digital is going down, and overall, the adoption of this technology continues to increase. So whole slide images are getting better, faster, and smaller. So we now have an ability to, within minutes, digitize a prostate needle biopsy, and I can consult a pathologist in real time within minutes. Something which would normally take hours to days, depending on where the pathologist is. So today there are several new companies, several new vendors in the space, and this field is rapidly evolving, very, very rapidly. So when I first started, there were maybe one or two vendors making scanners, but today there are multiple scanning companies, multiple AI companies, multiple workflow companies, multiple lab information systems. And so it's really the perfect storm for innovation and technologies. But at the end, as a pathologist, I love my H&E slide, right? I love my H&E slide, and that's the gold standard. But if you look at today, once you digitize the slide, you're now in the world of computational histology. So your slides are digitized, or your assets can potentially be digitized, and all this information can be managed digitally. So today, I, as a pathologist, if I have started to use digital pathology, all of my work can be done on these monitors, where I have the images, I have the patient information, I have my cases, and I can share these images with my colleagues. I can use these images for artificial intelligence, for image analysis, for analysis of breast markers. So there are several labs around the world who've gone completely digital. So in the Netherlands, the LabPON was the first clinical lab which went completely digital. So that you can see a pathologist here looking at their slides. They have all their cases on the left-hand side. Similarly, in the UK, several labs are now starting to go digital. So let's talk about artificial intelligence. So artificial intelligence is around us everywhere. Like if you look at Microsoft, Facebook, IBM, Google, Amazon, all these systems are utilizing artificial intelligence. So in pathology, there are many, many tools today which are utilizing artificial intelligence. natural language processing, speech recognition, building expert systems, planning, robotics. So if you look at the chemistry lab, a lot of the things have become robotic. If you look at machine learning, that's another area where pathology has already started using some of these tools. There are automated pap smear screening devices now. There are automated hematology blood smear recognition devices, which take a blood smear and separate the white blood cells from the red blood cells and identify atypical cells and present them to the pathologist. So if you look at other areas of medicine, so this is an example from radiation oncology, where imaging data was fed from 70 prostate cancer patients into 4 different deep learning models. And the model was able to devise 3D renderings of how best to distribute radiation. So the system was trying to design a method to choose what radiation oncology treatment would be best for this patient. And normally this would take, weeks for what a human would do, but AI could spit out a radiation roadmap within seconds. So that's incredible. If you look at radiology in reading mammograms, this is a paper that was recently published where AI tools help doctors to do a better job of finding breast cancer on mammograms. And this was done, research was done from Google and medical centers in the US and Britain. And this was published in Nature, where you can see that the yellow box indicates where an AI system found cancer, and this same focus was missed by 6 previous radiologists. So in this study, there was an absolute reduction of 5.7% in the US and 1.2% in the UK in false positives, and 9.4 and 2.7 in false negatives. So that's incredible. What about pathology? Pathology, there have been significant advances in the last 5 years on building AI tools for pathologists. So this is a company called Page AI, which has built a prostate cancer detection algorithm. So the computer has circled these areas which are prostate cancer and also assigned it a Gleason score of 3+3. So in the future, there will be many more tools like this which will help the pathologist. So people always ask me, is pathologist, if a pathologist is going to use digital pathology or AI systems, will these systems take over their work? Will these systems replace the pathologist? So this is a data from a study where the top AI system were asked to look for metastatic breast cancer in lymph nodes. And the error rate was 7.5% with the AI system. Pathologists were asked to review these lymph nodes, and their error rate was 3.5%. If you combine this pathologist review and the AI review, the error rate reduced to 0.5%. So as a pathologist, I would like to use a tool like this, which will actually help me improve my diagnosis, which will actually help me improve my accuracy and my speed. So this is just like another tool. It's not replacing the pathologist, it's helping the pathologist. So what about other areas of pathology? So this is breast pathology. This study was published recently, where in this study, 240 breast biopsies from different registries were tested and assessed using AI. So in this particular study, there were 3 expert pathologists who looked at 2 sets of image features, and they achieved a sensitivity and specificity which was comparable with 87 pathologists in the diagnosis of breast biopsy samples. So the point is, maybe as a pathologist, this is like a helper tool. This is a colleague, this is a virtual assistant who is helping the pathologist make these diagnoses. So it's not replacing the pathologist, it can be used as a decision support tool. In this study, there was for prostate cancer, again, our AI tools were built, which shows in this study, whole slide images from prostatectomy specimens were scored by 29 board certified pathologists. And the data showed the pathologist and in this study had a 66% Gleason score concordance. And if you add what the computer algorithms helped with it, there was a significant improvement in the score of prostate cancer. So if you look at overall the workflow involved in the use of AI methods. So as a pathologist, you get your slides, you review them under the microscope, you assign them a grade. Now imagine a world where these slides are now digitized. Once they are digitized, they are fed into this deep learning network where localized regions are isolated, image features of localized regions are segmented. And so you could look for mitosis, you can look for NC ratio, you can look at the cell density, and overall you're looking at, as a pathologist, we are very good with image recognition, we're very good with pattern recognition. So that's what we're doing. The computer systems are predicting patterns, they're creating profiles, and it's all based on mathematics, it's all based on statistics, and they're assigning it prognostic scores. So it's all about prediction. It's all about looking at the molecular features, looking at the digitized slide, and taking specific features in the histology and creating algorithms which can predict, is this H&E worse or better? So we should not be afraid of this technology. We should be thinking about how do we use it to improve the patient care? How do we use it to improve our workflow? Like you have a high workload when you come to work. So it'll be good to have some of these tools available to you to help you with your diagnoses. So this is an example of directed review. So you're looking at a lymph node, there are metastatic foci. So if you train the computer that these are cancer cells, these are metastatic cancer foci, you can provide example regions, then computer finds the matching regions, and you can use this for annotation, you can use it for quantification, you can use it for rare event detection. So let's say you have 100 lymph nodes to screen for patients with breast cancer. You can think of a world where you come to work and the computer has already digitized your slides and has screened it and found all the foci of metastatic cancer. And all you have to do is check it, make sure everything is okay, and move on to the next case. As a result of this, you have reduced a lot of the time that you would have spent in screening these lymph nodes, and you can use that time to go through your workload, to improve your diagnosis, to share your cases with your colleagues, and then teach residents, whatever the tasks that you are assigned to do on a particular day. This is a recent paper that came out on use of pathologist level classification and using artificial intelligence so on the left-hand side, you have these cases of lung cancer where the pathologist has annotated different types of adenocarcinomas in the lung. So lipidic pattern, the acinar pattern, papillary pattern, solid pattern, micropapillary pattern. So these annotations were then fed into the computer algorithm, and an algorithm was used to detect the same cases with using artificial intelligence. So if you overlay this, you can see the computer has done a really good job of finding the same areas that the pathologist found and also help subtype this. So my point is, today we have technologies available to us which enable us to become more accurate, which enable us to go through our workload more efficiently. So this was a study that just was recently published where an AI model was used for prostate cancer diagnosis in whole slide images of core needle biopsies. So in this case, there were two workflows. So there were glass slides, they were reviewed by a pathologist under the microscope, a diagnosis was rendered, and the same glass size was scanned and converted into digital slides. An AI model was used to make an inference on where the cancer is, and the data was then compared. So if you look at the data, this is a heat map of where the cancer is, and it shows you this algorithm achieved an accuracy area under the curve of 0.997% for cancer detection, so detecting cancer, prostate cancer. And it also was able to distinguish between low-grade cancer, so Gleason score 6, or atypical foci of cancer, versus high-grade cancer. So the accuracy was about 0.94% under the curve, AUC. This algorithm was also able to find perineural invasion and other factors that you, as a pathologist, report in your biopsies. So the point is, there are many advances today in pathology. So let's talk about what we have done in our university at the Ohio State University. So we are an academic pathology department. We have subspecialization. We also have general pathologists. We also have pathologists who are out in the community. So in January of 2017, we decided to create a digital pathology lab, and we got some space on the 18th floor of the cancer hospital. In May, we went live with purchasing digital scanners, and in July, we started to adopt and start scanning slides. So in the last 2 years, we also moved to a new lab information system, and we started to provide services to hospitals which were 20 miles to 80 miles away from our hospital. So our pathologists would travel to these hospitals. And then more recently, last year, right before COVID, we actually built a new lab, histology lab, which was off-site. So it was not on campus. It was about 3 miles away. And we were able to put digital scanners here. So as the slides were being prepared, as the H&E slides were being prepared, or immunostains or special stains, they were getting digitized. So we also built a consultation portal. So if any pathologist in the world wants to consult a pathologist at our institute, they can go to a website, log in, and send us a consult. We also started doing frozen sections and FNAs using digital microscopes. So this is a device which allows me to, when I'm on call for frozen sections or when I need to consult another colleague, this small scanner, which is about the size of a printer, allows me to connect to any pathologist on the website. We started to build a telepathology network, so starting to provide local consultations within the state, nationally provide consultation, and also globally. So we've started to do patient care pathology consults in other countries outside of the United States. So this is a small hospital which is about 90 minutes from Columbus, and more recently we implemented a small scanner here, which allows the pathologist who is rotating there to consult anyone on the main campus, and also to do frozen sections remotely. So about a month ago or so, we've scanned almost 1.7 million slides. So we have 104 total pathology faculty. That includes clinical, experimental, research, as well as anatomical pathologists. 41 pathologists are now approved for digital pathology reads, and we have 8 scanners which are deployed across the medical center. So we've gone live with primary diagnosis, we're doing telepathology, we're doing digital consults, we're doing resident training, clinical teaching conferences, tumor boards, proficiency testing, we're using image analysis on digital slides, so for breast cancer markers, and we're starting to collaborate with computer science department with PhD students who are actually building tools for pathologists, like looking for H. pylori in gastric biopsies or counting mitosis in sarcomas. So this is the workflow where slides are prepared in the lab, they're stained, they're digitized, and they're assembled automatically with the help of barcodes, and we can then automatically electronically distribute it to pathologists in their workstations. So what have we learned so far? We've learned that early adoption is a key, and we can start to create pathologists who become super users of the technology. We've also learned that things that make life easier for pathologists are more likely to get adopted. We've also had some early wins with review of retrospective cases and doing remote frozen sections. So it's really what motivates each one of us is very different. Some pathologists want to use this technology for efficiency gains. Some like the teaching aspect of it. Some are really interested in doing research with digital images. So we really saw a big uptake and adoption during COVID-19 in teaching, consultations, and sign-outs from home. So when the COVID hit us in April, we found there were pathologists who were not able to come to work, who were under quarantine, who had family childcare issues, who were at increased risk due to their age or pre-existing conditions, and we wanted to maintain social distancing. So this is a note on an OSU pathologist on their door during COVID-19 who was away. So she wrote down, "I'm off service and working from home with full remote access capabilities. I'm available via cell phone, pager, or email." So the point is, these pathologists were able to work remotely from home. They were able to sign out with the residents from home. They were able to, see all the cases they needed to see during COVID-19. And we are still in the middle of it. The number of cases in the US continues to increase. Yesterday we had 100,000 cases in the United States. So we've now moved to a new lab information system. We've also, again, I mentioned we moved to a new central lab. So this is the lab which we've moved to, and this shows you the scanners in the lab. These scanners have 1,800 slide capacity per load. They are located in the histology lab right adjacent to a cover slipper and scanner, and this is staffed every day from 5:30 a.m. to about 7 p.m. So this is an instrument we bought for staining of H&E slides and also for cover slipping, and the scanners are right next to it. So these are some examples of stains which are produced, the controls. So you can see the image quality is really good with not only H&E but special stains. So the image resolution and the resolution for looking at specific features like red blood cells or nuclei, nuclear membrane is really, really good. So you are able to see, these are some examples of different images, immunostains, special stains, silver stain for fungus, special stains. So this is now a part of the workload. So when the slides are created, it doesn't matter which order the slides were made. Because these slides have barcode, they get scanned and they're automatically assembled in front of the pathologist. So when I look at the cases in my computer, I can see the list of the cases. I can click on the images and I can launch the case images, and it opens up the H&E slide. And I can zoom up and down. I can go, I can look at the patient's information. I can order immunostains. So this shows you the workflow that we have created to review cases, immunostains. So scan slides are instantaneously available in the image management system. There is no waiting for delivery, no waiting on foldering. So as soon as I come to work, I have my list of cases, I have my work list, and I have the images right there. So I don't need the microscope, with the exception of in some cases. So this is the viewer that I use. So on here you can see the cases that I have to review for this case. This is the patient's accession number, patient's name, the date, the H&E slide. This is the thumbnail slide for navigation. And I can just click on the slide and view it. And these are some of the tools. So when I click on this collaboration tool, I can show this case to anyone. So this is an example where I invite a collaborator and I want to know, is this is a breast lesion? Is this atypical duct hyperplasia? Is this DCIS? I can collaborate. Multiple people can be looking at the same slide at the same time. So if I was teaching a seminar to you all, I can be showing you these digital slides and you could be logged in, just like you are logged in the Zoom seminar, and we could be interacting with one another, and I would be showing you these cases remotely. So we also send out our controls using digital slides now. We don't send out glass slide controls. We send out a case of the day where pathologists, residents, trainees can look at the image digitally and look at some possible answers. And the next day they get the next case and they get the answer to the case from the previous day. So during COVID, we saw a reduction in the number of prospective slides for scanning, so you can see, but then we came back up in April, end of April. And this shows you the number of slides that were scanned for pathologists for primary diagnosis. And this shows you the average number of slides per day. So it went down to about 1,400 during COVID, but then came back up to 1,800. So what can you do beyond the glass slides? So we can make glass slides, we can digitize the glass slides, but you might say, you know, what's the value of if you don't want to share these cases with each other? You know, we want to make a diagnosis on the glass slide. What else can you do with a glass slide? What beyond the glass slide that you cannot do on a glass slide? So once the slides is digitized, digital pathology opens new doors, new algorithms, new possibilities. You can create methods to identify features, quantify features, and synthesize this information. So for example, this is a patient with breast cancer, and you want to quantitate Ki67, or you want to quantitate ER, you want to quantitate you want to quantitate HER2/neu. Instead of counting every single cell or estimating how many positive nuclei are there, you can use image analysis, you can use machine learning for automatic tumor detection, automatic counting and scoring. You can work with tissue microarrays, you can work with full H&E slides. You can also do multiplexing where you can have 2 or 3 different markers on the same slide and quantitate each one individually or collectively. So this is an example of a study that just came out. So using deep learning and artificial intelligence to develop and analyze computational H&E staining of prostate core biopsies. So what you see here in row A are 5 different biopsies which are unstained. So patient biopsies are processed in the gross room. They are placed in paraffin blocks, and the sections are made, but they're not stained. So you're looking at unstained slides of these. In panel B, now you've stained it with H&E. So you can see this is A, this is B, these are H&E stained slides of the same unstained slides. What is remarkable in what you see in panel C is all these images have been generated using computational pathology. So this H&E stain is built by the computer. It's a artificial H&E image, artificial H&E slides from these unstained slides. So the computer was able to take the unstained slide and stain it using artificial intelligence. So let's take it a step further, right? So now if you ask the pathologist using a traditional H&E slide, which was stained in the lab, and ask them to annotate and mark cancer. And now let's ask the computer to find cancer. So take these unstained biopsy slides and ask the computer to find cancer. So these green overlays are areas that the computer has marked as cancer. And these are the benign glands which the computer has not marked. These are the benign glands the computer has not marked. So the point is, this is an exciting time in pathology, and we are poised for innovations. We're poised for new technologies which will disrupt pathology in many, many different ways. What we think about traditional H&E slide, which is stained in the lab, that may go away in the future. That may go away, and it may be possible to create, just from unstained slides, H&E slides. And so today there are several technologies out there. So this is an example of, let's go beyond whole slide imaging, where you've taken a glass slide and digitized it. So this is an example of another technology. So what you're looking at is a knife edge scanning microscope. So the patient's tissue is stained with H&E, and this block is then placed underwater, and these images are actually showing you three-dimensional views of the tissue. So this block is underwater, and it's getting cut by this knife, diamond knife, and while it's being cut, the H&E image or the image is being shown to the pathologist. So there is no glass slide. You're just making a film on water, and it's getting scanned by this microscope. So think about this. This is your patient's tissue, which has been stained, cut underwater, and the film which is on the water is being scanned. And you can see the resulting image is of really high quality. And this will keep improving. This is just some examples of new technologies that are making their way into pathology. This is OCT, optical coherence tomography, where you can see a complete cross-section of a fallopian tube. So here you can see an H&E image of a fallopian tube, and on the right-hand side you can see the OCT image. So, okay, the resolution is still not that great, but what a pathologist can see with a radiology image today, radiology-like image using OCT, is much more than you could see years ago. So as radiologists and radiology imaging technologies get more sophisticated, they're going to come to a level of an H&E resolution. And as pathologists, if we don't keep pushing the needle, if we don't keep learning new technologies like this, radiologists may be able to see this type of an image and even call it a fallopian tube in the future. So it's very important for pathologists to take ownership of these new technologies, because if not, somebody else will do it, right? So it's really an exciting time to be a pathologist. It's really an exciting time because there are many, many new innovations and new technologies which are available to pathologists today, which will make us better diagnosticians, which will make us and continue to play an important role in the patient's management. So we have an exciting journey ahead. The pathology lab, anatomical pathology lab, is continuing to transform. So you have new possibilities in your office now. You could look at all your cases, your slides, your workflow, and depending on what you are, if you're a breast pathologist, you're using IHC, or you're a molecular pathologist, you're looking at next generation sequencing. Pathologists will continue to be vital. There is no question about that in advances in clinical diagnostics. Not just anatomical pathologists, but clinical pathologists, molecular pathologists. We will continue to play an important role, but we need to be aware. We need to be thinking about new technologies like artificial intelligence, like digital pathology, like speech recognition, molecular pathology, and smart reporting, to continue to be an integral part, to continue to be vital, to continue to be relevant in healthcare and in clinical diagnostics and in cancer diagnostics. So this is a picture that one of my residents provided, where I'm not a hematopathologist, but if I have all the right tools, like shown here, I can use these AI tools and I can potentially look at areas that I had never even thought about and gain new knowledge which I didn't even think was possible, and be able to use AI assisted pathology. So the possibilities are endless once we think about new ways to automate pathology. So what we talked about today, that there are several challenges in pathology today. We are also seeing an explosion of knowledge. We are also seeing new innovations across the space. Pathology is evolving. Traditional pathology is evolving to address these changes, but not at the pace to keep up with all the new tools and technologies. We are poised for innovations which may be disruptive. We may be asked to do things which we've never done before, but it's important for us as pathologists to embrace these technologies. So with this, I'm going to stop my talk, and I really want to thank you for your attention. I want to thank Dr. Hussain for inviting me, for the symposium organizers, SKM symposium organizers, to inviting me to be with you virtually today. I wish I was there in Pakistan. I really wanted to come and visit my family in Karachi, but hopefully when things get better, I'll visit your institute as well. So thank you. I'm going to stop, and I'll be able to answer any questions that you might have.
Okay, thank you very much, Dr. Anil. And this was a magnificent talk. And we have few questions for you. First question is from Dr. Nadir. The question is digitization equating outsourcing?
No, so that was my point, right? So we can think about digital pathology as a way to insource. Like when you think about outsourcing, you're saying you're looking at opportunities which are going away from you. But digital pathology is actually going to bring opportunities to you. For example, at Shaukat Khanum, if you embrace digital pathology, you can now do consults for all patients all over Pakistan, India, Dubai. So it's actually opportunities to insource cases. It's not going to, it's not the same thing that we saw in radiology many years ago, where cases from the US were actually going to China or other places. It's going to be the other way around. It's going to be where the expertise is, where the pathologists are. And right now, for example, we are helping, we are volunteering in my university to look at patient biopsies in Africa, where there's a small scanner in a lab and patients need a review by an expert pathologist, and we are doing it in real time. We're also doing it for a fee. So we're actually creating insourcing opportunities.
Okay. So another question. It's a question from Dr. Irfan Bashir. So what about the use of artificial intelligence for frozen sections and cytology?
Yeah, so as I mentioned, in cytology, like there were already technologies several years ago for pap smears, where automatic reads of pap smears were happening, and the pathologist would not even look at the benign pap smears because they were read by the computer. Same thing is happening in hematology, where you have instruments called cellular vision, which take a peripheral blood smear and isolate the abnormal cells and present them to the pathologist. For frozen sections, we now have the ability to remotely review frozen sections, and it's not inconceivable for those images to be sent into a AI model to find abnormal cells. So let's say you're doing a frozen section for a lymph node, and the surgeon wants to know if there is metastatic cancer present. So using the models that I showed you, potentially the same AI tools could be used on frozen sections. But I'm not aware of any study where this was being done, but it could be done.
Okay, thank you very much again. And I think tomorrow we'll see you again almost at the same time for your rest of the 2 lectures.
Thank you so much. I look forward to it.
Thank you. Thank you very much. So we have few more minutes for the next lecture. Okay, Dr. Alia has just joined. And so this is the time for Dr. Alia. And we are honored again because it's 6 a.m. in the US right now, and she is willing to give her talk, sorry. Dr. Alia Hussain is currently professor of anatomical pathology at the University of Chicago. She has done subspecialty boards in pediatric pathology, thoracic and lung pathology. She is co-director of medical student course, clinical pathophysiology and therapeutics. She is also director of thoracic surgical pathology fellowship. Moreover, she has more than 80 invited lectures, 49 chapters, 159 abstracts, and more than 200 peer-reviewed publications. First, she has a lecture about pathology of COVID-19, histological, immunological, and ultrastructural studies of 16 cases. And after that, she has a slide seminar on pathology of post-chemotherapy resections of pediatric tumors, neuroblastoma, Wilms tumor, osteosarcoma, rhabdomyosarcoma, and malignant teratoma. Now over to Dr. Alia Hussain.
Okay, Assalamu alaikum. It's a pleasure to be here so early, but you know, after all, it's not a big deal. Okay, so the one thing I don't know is how many people are here attending. Do you have any idea?
Yeah, there are almost.
Oh, I see
80.
it now. Yes, I see
Almost,
the participants now. Okay, good. All right, so I'm going to start sharing my screen, and then we can, let's make sure everybody, okay, you can see my screen?
Yes, we can see.
Okay, good. I've had some issues with it before. So I know that this is a cancer symposium, and I am really honored to have been invited back. I was in person there last year and really enjoyed meeting many people there. But you know, given the circumstances and the reason why we are doing this all on Zoom, I thought that giving some pathology on COVID-19 would be appropriate. Although I understand that the majority of the audience may be only dealing with cancer patients, but those patients also get COVID, and I have a small part in this about that. So let's get started, and feel free to ask questions as I talk. This is a very informal presentation, and I'll be happy to discuss any point, and especially if there is something that's particular to your setting that I have not addressed or I may be able to say something about, I'll be happy to talk about it. So I'm going to begin by some background, what our autopsy protocol is for doing COVID-19 patients, gross and histologic findings, which will be the majority of the presentation, comparison with fatal influenza cases, and then some special studies, because there's not that much literature on what works well in making it, in finding the virus on tissue sections. So I'm going to show you our experience in immunohistochemistry, in situ hybridization, and electron microscopy on selected cases. And then finally, I will end up with what's known a little bit on COVID-19 and cancer and how that is affected. So to give you some background, University of Chicago is a private university, is about 130 years old or so, just about, and is located in the south side of Chicago. So this is Cook County map. We are about here. So the main downtown and the areas that you're familiar with, the high rises, are in about this area. And you can see that the incidence of, or the confirmed COVID deaths are less in what is likely the more affluent areas, and then the peripheral, although that part probably is not that, but the west and the south loop maybe has more. So each county has been, or each neighborhood has been affected somewhat differently, but this was data from a couple of months ago already. So now maybe things are changing, but you'll see. So anyway, so we were in the middle of it. Also, we are the only university for the about 7-8 miles around. So we get a lot of cases, especially from the south side of Chicago. And we were a referral center. We became a referral center for COVID-19 patients. So this graph kind of gives you the timeline of how this pandemic has unfolded from March through September, October here, when we first started seeing the cases. So this is the positivity rate of the number of people tested. So at its peak, we were at 30% of the patients of the test becoming positive. But remember that at that time, we were only testing symptomatic patients, and there were not enough tests to go around to cover everybody. Whereas now, later on, we are down to about 5%, between 4 and 5% in Illinois. And it's we're certainly testing a lot more patients than before. So 3/17 is when our work from home order came, but the physicians, including the pathologists, all stayed at work. We sent part of our residents who were on electives to home, but the rest of the staff was here. The autopsy protocol, so we started getting autopsy requests early on, but we were not equipped to do it because we had not done such a contagious autopsy before. We do others. We certainly do, tuberculosis and even Jakob-Creutzfeldt, which is the most mysterious and difficult one to do under the hood. But there were protocols for that anyway. So we developed an autopsy protocol based on CDC guidelines. And it took us some time, almost a week or more, to get all our operating procedures in place. We also had to train a core group of people to do it. So that took us another 2 weeks till we could actually perform the first autopsy. The training included proper precautions and use of the space and making sure. In July is when we started finally getting our IHC and the in situ hybridization kits. They were not really reliable or that much available before then. And then after that, we've been just continuing to see a few cases. Actually, in this last 1 week, though, the cases have picked up again. We were down to about seeing 1 case every 3 or 4 weeks, and now we are at 3 cases a week again. So it's really has gone up recently. So to date, we've done 26 COVID autopsies. Actually, we did the 27th one yesterday. And this is what our old morgue used to look like. I don't know if any of you remember seeing it. It was really old. It was a negative. There was no negative pressure. It was only in certain areas. There was a room behind that had negative pressure. Autopsies could be done. So infectious autopsies really was not a good idea to be done. To give you an idea of how old this morgue is, this is where can you recognize which movie was filmed here? I don't know. I guess everybody's muted, so I can't really ask questions. But you can put something in the chat box. I can't even see the chat box here right now. But anyway, so The Fugitive, the movie was filmed here. And this is when Rex has, this was our dinner at the time. The morgue then had been in the process of getting updated and moved. So we now have a state-of-the-art morgue with negative pressure everywhere, so we can do all the autopsies we need to in there. The team, we decided, would be only a few people that volunteered to do it, and none of them could be over age 60. So I personally did not do any autopsy. Dr. Mueller here is our chief of the autopsy service, and he's been involved in almost all the autopsies. Dr. Pytel is a neuropathologist, has done many. Phil McMullen is my fellow. He was a resident at the time we started and has done the majority of the more autopsies than any other resident, and this is our autopsy assistant or the pathology assistant. There are a couple of other residents also involved, but I really want to thank Phil and Jeff for all the work that they've done and provided the material for this presentation. So there had to be a very well worked out flow of where everybody would be, so you are not bumping into each other or exposing the other person with your instruments while you are cutting. So they had a plan for where would that one person stand, where is the dissection table. Then they would hand the organs over to the second person who would be taking photographs. So at the time that they did the autopsy, they only weighed the organ and they took them out organ by organ from the body, So you know that there are two ways of doing autopsies. You could either do the en bloc resection, put the block on a surface and then dissect out each organ. The other one is that from the body, you take out one organ at a time, which actually leads to less exposure. The dissection may not be as pretty, but that's not what we needed at this point. So they took out the organs, they would give them to the photographer, they would weigh it, photograph it, cut into just so that it would get enough for formalin, and they would have everything else ready in advance, all the containers with formalin lined up, all the instruments lined up in advance, and they just put the specimen in the container. So then the gross organs had to fix for 72 hours to inactivate the virus. Okay, now that the organs were fixed, then they would go back 3 days later and section the organs. And we sampled everything. Of course, the lungs were sampled very, very extensively, since clinically the majority of the disease appeared to be in the lungs, although there are other organ systems that are affected. So we did take some sections from the airways as well, including the nasal passages. We tried to get to the nasopharynx, but that was not possible. Oh, one other thing, before we started the autopsy, we did do a nasopharyngeal swab in the majority of them. The first few ones we weren't set up to do it, and sent it to microbiology. Actually, we do that now for all our autopsies because you need to be sure what you're dealing with as you do the autopsy. So they would give us an answer within an hour. So now we had to wait to get the autopsy started until you knew. And all the COVID autopsies tested positive, except for one. Now, that doesn't mean that they were all infectious, as we have found out. Being PCR positive is different than being infectious, but more on that later. So we were starting out knowing that these are going to be positive, and so you have to be really careful. We took lots of sections. We sectioned the heart, the liver, spleen, kidney, bone marrow, and we took nasal biopsies in 8 cases to see what the changes were, since the portal of entry of the virus is the nose. Dr. Pytel is a neuropathologist, so he wanted to see what were the changes in the psoas muscle and sciatic nerve, and then took some nerves there and nerves. What we have not been, we've only recently started taking brain and spinal cord sections. So just the last 3 cases now that we had to get a special covering for the bone saw so it would not aerosolize when you were cutting the bone. So those results are not part of this presentation. We are actually still fixing them. They have not been cut yet. We did take endocrine organs as well. On an average, 34 blocks per case. So to date, we've done 26 cases, but I'm describing 16. The average age of these 16 patients, so now everything else after this is going to be for the 16 patients that I'm giving you the summary on. So as we've known that most of these patients tend to be older, and that is what it is. However, there are some younger patients. Now, actually one of these 26, our youngest so far is a 23-year-old. And I'll come into a little bit more detail of what's going on with them. So of these 16, the vast majority are African American. So 2/3 are African American. There were 3 Hispanic patients, or 20%, and only 2 Caucasian. So partly this reflects the location of the University of Chicago, which is more in the south side. So our patient population, even though I think the percent of Blacks in this country are, I'm not sure, 12% or 15%, something like that. Our catchment is at least 40% African American, and then they are more likely to die. So there were even more African Americans in this group. The average length of admission was 14 days, but it varied so much. There was a couple of patients that died within an hour or 2 of arriving in the emergency room because they were just so sick and could not be saved. So we do have cases that were untreated relative to COVID. And so those findings will be compared to the patients that lived much longer, up to 2 months. These are the patients who were intubated. These long-term patients have been intubated over time. And you also know that the intubation and putting them on a respirator was very high in the beginning and then has gone down. So that has changed how the findings that we are looking at in the autopsies. So overall, though, more than 2/3 required mechanical ventilation, and the average length of mechanical ventilation was 15 days. I think that these numbers will change as our experience has changed. 7 cases were elderly, meaning over 65. I'm almost there, not quite elderly, but all the patients had comorbidities. I think that is a key finding that all the other studies have also been showing, that the risk of death is highest if you have an underlying disease. But it's not to say that if you have, say, kidney disease, you can have a normal life expectancy with appropriate treatment, dialysis, transplants, whatever. It doesn't mean that these patients were on the edge of dying or would have died in the next 1 year or 2. Half the patients, at least, I think, were such that they would have lived a relatively normal lifespan, but it's the COVID that pushed them over the edge. So what were these comorbidities? They ranged from diabetes, was the most common, dementia. We did have several elderly patients that were transferred to our facility from nursing home. So those were the 5 cases that were demented or had prior CVAs. 3 cases had currently advanced malignancy. One of these patients, the older one, had a malignancy in the past many years ago, had no evidence of tumor now, so we didn't count them as a malignant case. And 3 patients had only morbid obesity. So as you can see, maybe other than maybe the dementia and the advanced malignancy cases would probably not have a normal life expectancy, but the rest of them, at least so half the patient, more than half the patient population probably would have. So how were they treated then? As not all of these things are really anti-COVID therapy, but 11 patients got some treatment that at the time. 8 got remdesivir. There was 5 for this antiviral, 3 hydroxychloroquine. As you know, that currently it is not thought to be an antiviral, and so consider that as placebo. So really, of the 8, of the 11, so there are more drugs than 11 patients because some of them got multiple treatments, multiple drugs at the same time. Almost all were anticoagulated. And this is really important to remember because remember, we are going to be looking at autopsies. It's a reflection of what happens to the patient more towards the end of life, may not necessarily reflect all the events that happened a week or 2 or 3 weeks ago. So if they were all anticoagulated, the number of patients that we may find thrombi in may not be reflective of what was happening during life. But that was it. Heparin was the most common drug that was given. Only 2 patients of this group received convalescent plasma. We do continue to use it as part of a study here, but the effectiveness of this therapy is in question. Maybe it decreases the severity, but that's about it. I don't think it cures people or prevents death. So from the data that we know so far. Okay. So antibiotics were given a lot and often multiple of them. And that actually makes a lot of sense because these patients developed superimposed pneumonia in many instances. So only the 2 patients that came and died within the first 4 hours of arrival here received no anti-COVID medication, nor did they get any antibiotic or plasma. So those were the ones that we'll show you as what the changes were. The pathology in those 2 patients is truly due to COVID only and not modified by anything else. So moving on, I don't know if anybody would like to, the panelists or anybody else, if they're unmuted, if you can ask a question, please go ahead. I'm not so sure if anybody would like to.
think questions will be asked at the end of session.
Okay, fine. All right. So summarizing the lab data, there was a lot more lab data that was available that I don't think was relevant as much, but the most important was that the respiratory cultures that were taken either pre-mortem or post-mortem grew organisms in several of them, from Pseudomonas, MRSA, Proteus, MSSA, staph. So in overall, in 1/3 of the patient, almost 1/3 of the patients, there was a culture, a positive culture was present. The D-dimers, which is a reflection of how much thrombosis is occurring, or DIC, or clotting, there were, for half the patients, the D-dimers were raised over 20. And this was at some time during life, not necessarily at the time of death, because they'd already been anticoagulated by then, but that clinically there was significant thrombosis occurring in at least half the patients. So that fits in with what has been reported throughout the world now in these patients. All right, so moving on to what the gross pathology shows. The most significant finding were in the lungs. They were always abnormal and showed abnormality of varying degrees. At least, if nothing else, then the weight was higher, and average weight, as you know, is about 350, 400 grams, 400 for the right, 350 for the left. And so they were twice the weight of a normal adult lung. So then what was making them so heavy? There was consolidation seen grossly, which was bilateral in some and diffuse or focal in others in 9 cases. There was hemorrhagic parenchyma in 3, and then gross thrombi were only seen in 1. So microscopic thrombi is a different story, but gross thrombi, we didn't see that much. I mean, that is also understandable considering that the 88% of the patients were anticoagulated, that you would think that they would not get gross thrombi then. 1 case had acral ischemia secondary to thrombosis. The fingers and toes were all almost gangrenous looking because there was so much widespread thrombosis in this patient. One of the things we found was that, just looking at grossly, that all the other organs looked appropriate for what the underlying pathology was. So if the patient did have ischemic heart disease, there would be findings of those, or had end-stage kidney disease, you would see that. But nothing to us looked like it was none of the gross changes seemed to be attributable to COVID-19. So for example, we found no unexplained infarcts anywhere, kidney, liver, or spleen, that would be, we would say, due to thrombosis or something like that. So no COVID-specific findings. So here are 2 sets of lungs, 2 lungs. Here's an outside, the pleural view. It shows some hemorrhage even in the pleura, and on the cut surface, you can appreciate the area of consolidation in this one, and extensive consolidation and with some hemorrhagic component probably in this one. So the lungs were heavy, often consolidated, hemorrhagic, and microscopically, the findings range from diffuse alveolar damage, which would be the equivalent of ARDS clinically, but definitely finding hyaline membranes was the most common feature of this disease. We found them in 75% of patients, and it is seen here. In this one, it looks like there's some nuclei maybe starting to grow over it and maybe starting to get incorporated. And they are not complete throughout, because I think that some of them are either fallen in, but those are pretty convincing hyaline membranes there. Same thing here, more hyaline membranes that are seen in the lungs. Some with variable amount of hemorrhage. But other than that, if you look in the background, there are some lymphocytic infiltrates, and I'll talk a little bit more about them later, but it looks, as you would expect in a viral pneumonia, That's what we saw in some of the patients, that there were background lymphocytes. Microscopically, we found organizing thrombi in many more patients than we thought we would. There was 63% of them that had, only one had gross. This is the one that had the gross thrombi. I appreciate that the fibroblasts are growing into the clot already, so this clot has been there 3 or 4 days, and others were more recent and only seen microscopically. So we were sampling extensively, looking at 3 sections per lobe. So to find thrombi, I don't know how significant that is, but knowing that at least 88% of the patients had been anticoagulated, but half of them had increased D-dimers, I think it all sort of fits into that picture. So after those findings, then now come the superimposed. I think the thrombi are also probably not due to direct infection of the endothelium, but I don't know that we really understand why there are thrombi that form in these patients. From what I've read, it seems that actually they are saying that there might be direct damage to the endothelium, which leads to more leakage of fluid as well as thrombosis, but I'm not so sure that that's proven yet, but we are looking at it. I may digress a little bit, but we did look at the blood vessels using both in situ hybridization and electron microscopy and immunohistochemistry, and we actually were not able to demonstrate any virus within endothelial cells. So direct infection, at least we have not been able to show yet. Okay, so moving on. Superimposed bacterial pneumonia was seen in little more than half the patients. Some of them had aspirated material associated with it, so we think that that's what started it, since there were, maybe the aspiration occurred before they were intubated. We don't think that patients who are already intubated would aspirate that much, but I'm not sure as to the timeline. However, the pneumonias were extensive and really, as you can see here, filling the alveolar spaces with neutrophils. And here is some foreign material in this patient. So bacterial pneumonia, because of the neutrophils, now that I think about it, I don't think that we were taking postmortem cultures, because in order to culture, we had to have a high-level hood and lab for the specimen, and I don't think we did that, at least not in the beginning. I don't know if we're doing that now. We'll see. But so the changes ranged from superimposed pneumonia to hemorrhage and infarction here, which in these pictures you can see at the edge here, maybe there was associated with the pneumonia, but these may not. The infarction I did not think was secondary to the pneumonic infiltrate, it was not a necrotizing pneumonia in most of them. It seems like there was a bacterial pneumonia, and then an infarction may be secondary to the thrombosis. I should close the door. It is 5:30 in the morning here, so I think our cleaning people are starting to show up. All right, so now looking at the lung itself, the most striking finding that we found were these very reactive looking pneumocytes. As you can appreciate, here's a whole row of them lining the alveolar walls. Within the alveolar wall, there is a lymphoplasmacytic inflammation here. And then down here at the bottom, probably some neutrophils as well. So it's a mixed picture of whether this patient was infected or not, but certainly the pneumocytes are florid. There are prominent nucleoli in them. And then the cytoplasm, and I'll show you some more, looked sort of almost finely vacuolated with even some bluish granular material in it. The nucleoli are multiple, as you can see here. And we originally were wondering if these would prove to be viral inclusions. And actually they are not, they are just nucleoli. So this virus is only in the cytoplasm, not in the nucleus, is where we found it eventually. But that's the picture that makes you think that these are virally infected cells. And then these are the cells that we targeted. So to perform electron microscopy, we micro dissected out these or punched these areas of the block and then deparaffinized and submitted for electron microscopy here. So to summarize the pulmonary findings, there was, we tried to look at it in over time, how long the patient was admitted, from 1 to 9 days, 10 to 19 days, and more than 20 days. And that is because we think that the pathology will evolve depending on how long the patient is admitted and whether there's been time for those hyaline membranes to organize or not. And that's exactly what we found, that in the patients who had shorter stays, there was early diffuse alveolar damage with those very florid hyaline membranes, more likely, and those were seen less often in patients who had been admitted longer. Organization was only seen after a couple of weeks or so, and in those patients that were more than 40 days. Also, in each group, there were 7 patients in this 1 to 9 group, 5 in 10 to 19, and 4 in the greater to 20. Bronchopneumonia seems about equal, and the rest of it, aspiration pneumonia, doesn't seem to be changed much. But these reactive pneumocytes that I've been showing you, they were seen much more often in the early to mid-range group and not seen in the late group. And actually, if you think about it, I mean, all of these are just reactive pneumocytes, but if these are really reactive secondary to the virus, we do think that the body can clear the virus within a week or 2. And then the patients who are sicker longer than that are because they've had the cytokine storm and have had other complications superimposed on it. And so they continue to be sick. So the concept being that early on, it's the direct viral toxicity that's making the patient sick, stimulating the immune system, and thus causing the ARDS, diffuse alveolar damage, early on. And then as the inflammatory system gets revved up out of proportion to what is helpful, that's when you get into the second phase of the disease. So I think these kind of bear out with that. Thrombi were about the same throughout. I think some of these are microthrombi, not necessarily gross. So the gross thrombi was only in 1. Infarction in a small percentage of patients throughout, same thing for hemorrhage. So of all the changes seen in the lung, a time course could be seen in the diffuse alveolar damage and the reactive pneumocytes. All right, so that much was for the lung. Moving on to other organ systems now. The second system that we thought was very significant were the lymph nodes. So the majority of the lymph nodes sampled are mediastinal lymph nodes, but then we did have some abdominal lymph nodes that were also sampled. But what we saw, that the majority of the lymph nodes looked depleted actually. They were few, so it's like here you can see, this is an anthracotic lymph node, so this is mediastinal, but there were fewer lymphocytes. There were some large reactive looking cells. They turned out to be histiocytes, maybe a few immune cells, immunoblasts, but not that, nothing that really has us give an actual diagnosis for what is going on in it, other than saying that the lymphocytes are getting mobilized and moved out in response to the viral infection. So that's why about 70% of these lymph nodes look depleted. There was hemophagocytosis seen in 30%, and there were small thrombi, maybe one seen here, that was present within the lymph node. So we also did the same electron microscopy and as well as immunohistochemistry on the lymph nodes to see if you could find virus in here. And to date, we have not been able to, but all the cases have not yet been done. We've only done a selected few for these. The lungs have all been done. So All the other organ systems, basically, we did not find anything that was specific to the disease microscopically as well. The heart would show the underlying disorder that was present. We looked very carefully, and we have actually applied for a grant to study cardiac changes because there is a lot of clinical interest in what is happening to the heart, because these patients are developing symptoms of heart disease. And so we are particularly focusing on looking at the endothelial cell damage, microthrombi, and so that study is ongoing, and we will present that hopefully another time. The kidney did have some, about a third of the patients had microthrombi, but that was the same as we were seeing in any others. And we did not think that there was any vasculitis. The liver showed spleen, bone marrow, nothing. In this 16, there was no brain or cord. So having done all of this and having looked at all the autopsies, we were trying to decide, what does this mean in a patient that has a viral infection? Are these findings specific to COVID-19, any of the ones that we have seen? So we decided to compare to our autopsy cases of fatal influenza that we've had over the years. And we've had several cases. It was not difficult to find them. So I went back 3 years ago, so that we were not in the COVID phase at all, and found the 6 patients that we had. So these were collected between 2015 and 18. And the age range was 46. So now, if you compare, the age range for our initial COVID group was 65. So these patients are two decades younger. So you would think that there would be even more of an outcry over flu, that it kills younger patients. But remember, these are only 6 patients. It is not reflective maybe of the whole population. And we had a huge range. Maybe the one that's skewing it is the 17-year-old who had underlying, I believe, cardiac disease. All of them were African-American, which may be a reflection of our population, but still, to pick 6 patients, all the 6 patients who died of flu over 3 years, be all African-American, I think is more than just coincidental. We'll do, I don't know if the numbers are enough to do a p-value, but to my eye, it looks certainly significant. So it is not just that it is COVID-19 that kills them more, other diseases do too. And we've known that a long time, that their life expectancy is not as long as Caucasian. And they do have more obesity, hypertension, and diabetes. So, and all 3 of those are very significant comorbidities for and risk of dying for these patients. So all of them were African-American. And 4 of the 6 had concurrent medical conditions. Oh, that 17-year-old was the Downs patient. There was one who had a glioblastoma and one was diabetic. But then but there were certainly several that were older as well. So we've put older than 65 as a risk factor also. So they all had risk factors. Average length of admission was 5.7 days, which is a little bit shorter, but we do have fewer patients here. 5 of the 6 were mechanically ventilated, and for an average of 5 days. So that mechanical ventilation for viral infections, I guess, has been around, was the state-of-the-art treatment until this summer when things changed. But I think patients were being treated that way for flu as well. They all, again, a third of them had significant respiratory cultures with Staph aureus in both. In a similar way to COVID-19, in which we had about a third of the patients have significant cultures. So superimposed infection after a bacterial infection after a viral infection is common between both of these. Again, 3 cases had D-dimers greater than 20. The other 3, no D-dimers were performed. So if you think about all this talk of thrombosis in COVID-19, thrombosis was occurring, or DIC was also occurring in patients with fatal flu. So that all the ones that were tested, the D dimers were high. And in one of the patients in which no D dimer was performed, he was treated for thromboembolism. So four of the 6 we know had clinical diagnosis of hypercoagulability or evidence of thrombosis. So that's also very significant. So that COVID-19 is not that different from flu. Microscopically, we found very similar things also, that there was hemorrhage, DAD, there was some lymphocytic inflammation, superimposed infections, and thrombi and infarctions. So if you were to give me a slide of H flu that the patient had died of or COVID-19, I don't think I could tell the difference. Maybe there is slight difference in the type of reactive pneumocytes, but I don't know if I'm blinded to what the case is. I don't know that I would be able to find it. All right. So to summarize, the findings in H flu, in fatal cases of flu, are very similar to those of COVID-19. All right, so I'm going to spend a few minutes now talking about, which is close to our heart, how can you make a diagnosis by IHC, which is the easiest one to do. And in situ hybridization, we did find the kit. The kits are easy to use, and I'll show you what it is. So what are the challenges in doing IHC? If you read the literature, there are a lot of people that have published saying, oh, here's an IHC stain, it's positive, so there is virus here. That is why you have the papers saying that virus can be detected in the kidney, in the lymph nodes, in the brain, in all kinds of organs, in the GI tract, in the skin, all the areas that there are symptoms. If you do an IHC stain, you may find some positivity. That is because many of those studies had no true positive controls. And at that time, we also didn't have a true positive control. We've also learned that being PCR positive doesn't mean that there's virus in the tissues. That just tells you that there is residual RNA left there that you're doing. So there's that. Then what is the distribution of the virus? We were not sure which tissues would be positive or negative. Is the process diffuse or patchy? Is it one cell or multiple targets? There's a high level of background and non-specific staining, so it's not easy to interpret. And then is there cross-reactivity with other organisms or normal proteins and sequences? So all of that needed to be worked through. And then is your IHC even working appropriately? So how to address these, and also then the stability of RNA in the postmortem tissue. So now how to address these issues, or what did we do? So we purchased a monoclonal we did do both polyclonal and monoclonal antibodies and tested those, and I'll show you the results. Obviously, the monoclonal worked better. We had we tested for RNA to make sure that that was, on these autopsy materials, that was not degraded, and tested for other viruses and in known patients to make sure that that was working. Then to get a positive control of COVID, we were given, or we got a cell culture. It was a suspension of cell culture of primate cells that had been infected in vitro with COVID-19. And of the cell culture, we spun it down, created a block, and cut serial sections for our control. And I'll show you those. So this is that cell culture. The H&Es at the top, you can see the epithelial cells. They do look kind of reactive, but there's no identifiable inclusion that you can see on H&E. By IHC, the monoclonal works very well, and the in situ hybridization also works on the same cells. So we were very happy with our control. Now, when we turned to looking at the sections, the polyclonal rabbit antibody that's shown here has a lot of background staining, so we stopped. We did not use it any further. The monoclonal worked really well. In the low power view, appreciate that these distribution of cells is very patchy. So it's not that the whole lung would be infected, at least not at the time of the autopsy. Maybe it was earlier on, we cannot say. What you have to remember is that in some areas, the virus is still there, in other areas it's not. So when it is positive, they are scattered single cells, and we think that these are all epithelial cells. Here it is at higher power, trying to match the same area to the area. These were those reactive pneumocytes I had shown you before that are lining the alveoli, and those are the same cells that are being stained by the immunohistochemistry, the monoclonal antibody 1 to 200 dilution, and that worked the best for us. Here is another area to show that sometimes, if I was to not know what I'm looking at, and we all look at so much IHC, you would look at this and say, it's hard to call that positive. Are those macrophages? It's so granular, patchy. Is it a non-specific staining? I think without the proper controls, the context, but if you look at it in the context, are you going to be then biased? Because I know that this is a COVID patient, that this is a COVID antibody, so would I call it positive? I think the interpretation of IHC is not easy. Same here. If you appreciate, those are the surface cells. Here is a cluster of cells. Some of them are epithelial, probably, that have dropped in. Some are macrophages. There are some positivity here, some there. But after comparing to the in situ hybridization, we were confident that this kind of dot-like or patchy cytoplasmic staining is indeed the virus. So here are those same pneumocytes, the same sort of area that we are trying to compare, and the in situ hybridization picks up the same cells that the IHC was picking up. It is much cleaner, much more sensitive, much more specific also. So we tend to get no background staining with the in situ hybridization. Here is another area to show you some of this material. Maybe those are pneumocytes in here that are positive, or at least they're desquamated cells that are positive. Not everything that looked like reactive pneumocytes stained. Here are areas that you would think, oh, these really look like infected cells, but they were not positive, either by IHC nor by ISH. So how accurate was IHC in diagnosis? So we did, our residents, Phil, put together 2 survey sets composed of 10 cases each. He got these 6 cases of fatal influenza cases, and then as well as other non-COVID pathologies, and didn't tell us, and then 4 of the COVID cases. So they mixed and maxed. Of the 20 cases were randomly distributed between COVID and others. So we got, they were blinded, randomized, and given to us board certified pathologists with over 60 years of cumulative experience. I mean, we have a lot of experience between the 6 of us. Over 60, I think we had over 100 cases, 100 years of experience between us. Okay, so the cases, the cell block was provided as a positive control, so you knew what to do. And then the tissue that we had called positive was provided as a control. It was really difficult. I remember looking at those cases and saying, I really don't know which one is which. So the results were that of the 8 cases, only 3 were called positive by IHC with 50%, greater than 50% concordance. Yeah, that means that all of us pathologists, only half of us or greater than half of us agreed on 3 cases only. The 12 cases that were non-COVID, 2 cases were called positive by more than half of us. So that means if you're truly blinded, if you really don't know what is going on, I think interpretation was not given. So what caused the false positive? I think education and learning is important. This is a case that was called positive. As you can appreciate, there's a lot of necrosis and inflammation. And these things that are positive are actually what turned out to be, this is a gram stain. These were gram-positive cocci. So you can see the cocci and H&E and ignore those. But what was important was that the macrophages in the vicinity that have engulfed the cocci also stained positive. So, and led us to calling this case positive, whereas you can see that the in situ hybridization is very clean and no staining there. So it is patchy, the viral distribution is patchy. Multiple blocks need to be looked at. Some bacteria cross-react. You do need to correlate with both H&E and look at the virus. And that there are a lot of bacterial superinfections that can lead to false positive diagnoses. But the ISH was able to resolve these false positive cases. All right, so what about electron microscopy now? EM we thought originally would be the gold standard, but it really turned out not to be. And that's because of postmortem degeneration. There are many cellular components that can resemble virions, and the patchiness of the virus made it difficult to find it. You would need to have gold-labeled antibodies to confirm it, which we haven't done yet, but eventually we may try and do it. So with all of these correlations, we tried to find EM. And this is the CDC's image of what they colored it blue. It's not blue, obviously. But if you look past the blue, you have it has to have both internal structures, these globules, as well as externally on the surface of it. That's what you're looking for an 80 to 120 nanometer particle. So we targeted these pneumocytes and looked at them. As you can see, post-mortem, EM is not that easy to interpret. There were a lot of organelles in here that are degenerated, but at high power, these are the best that we found. We really think that these are most likely to be viral particles, but we could only confirm them in a few cases. I think we've done 8, and we could only confirm them in 3 or so, and that's it. But all the other things, there are so many artifacts. If you look around, and we looked at cases that were not COVID, you can find the most problematic is this clathrin-coated vesicles, which can look very much like viruses. And you can get degenerative vacuoles and polyribosomes, and here too. So if you have a picture like this, I think a naive person would say, oh, these are viral particles, but they're not. These are all artifacts or all other structures. So to conclude on the ancillary methods, we found that IHC actually is useful if you are cautious and remember that bacteria can give you false positive. Sampling is important, and that cases with protracted clinical course, if there's more organizing DAD, they may be completely negative. So not to say that they weren't there before. The in situ hybridization and IHC show concordant patterns, and ISH was more specific. And EM is not discouraged for primary diagnosis. If you have the ways to do gold-labeled proof, then you can do that. Post-mortem degeneration is really a problem. So finally, I want to show you just a couple of slides on the work done by Phil, my fellow, on platelets and pathogens. He's been working on platelets actually well before COVID-19 came about, but when it did, he was interested in how platelets play a role in infection and had been studying them. And so platelets have been shown to be significantly present here in capillaries in various conditions, including infections, DAD, here are megakaryocytes. And and that they think that they may be mechanoscavengers that collect and bundle bacteria. So there is a role that platelets play in controlling infection. So he looked for that in our COVID series and found these microthrombi of platelets, which is just a paper that was published in American Journal of Clinical Pathology last month, comparing those with the flu cases. And what he found was that the platelets are increased above normal lung, but so are they increased in many other conditions, including fungal infections, pulmonary thromboembolism, and influenza. So platelets are increased. We've known that, and this demonstrates that fact. Here they are on high power in a series of COVID patients to show you that you can find platelet thrombi in the lungs and other organs as well, actually, not just in the lungs. So both megakaryocytes and platelet thrombi are not specific to COVID-19, but represent common responses. And they're seen in all kinds, both infectious and non-infectious causes. And then what is their role, or is there any specific role in COVID-19? We're not sure, but just like other infections, yes, they are present. And they may have specific interactions with microorganisms. All right, so the last couple of slides are on, or one slide actually, is only on COVID-19 and cancer. So of our autopsies, there were 3 that had solid organ, that had extensive cancer. And we don't know, if you look at our whole hospital, our patients are probably, I would say, at least a third of our patients are cancer patients. So if a third of our autopsies had cancer, it doesn't seem to us that the cancer patients were any more likely to die of, or to get it or to die of COVID. But this is a very small group, and we really cannot make any conclusions based on our 16 patients. As our experience increases, maybe we'll look into this some more. But recently, an abstract was presented from Memorial Sloan Kettering on 90 patients with active or recent cancer who developed COVID and were admitted in New York over March to May. Of these patients, 60 had mechanical ventilation. So that's 2/3. Remember, this is the early phase of COVID. They were being put on mechanical ventilation much more than we would do now. So keep that in mind, that almost 40% of them died compared to the non-ventilated ones. So we are not sure if the ones that died had more severe disease. Did their cancer make any difference to them? But overall, this kind of mortality in March to May seems to be almost comparable, because they've said that mortality was maybe 30% if you look at the ventilated patients overall in that time period. So maybe mortality was slightly increased, but not drastically as compared to other patients who had COVID-19. So having cancer and COVID doesn't mean that you will that it's a death sentence. The patients are surviving in this situation as well. So a lot of people to thank who were involved in putting together the autopsies, working with us, especially the clinicians, the pathologists, and all the core people that are here. And I'd like to end on this slide, which is a picture of a statue by the Art Institute in Chicago. And what this is showing here is these 5 statues represent the Great Lakes. And there is water flowing from here down all the way to each one of them and out, and then it gets recirculated and gets flown, and then it flows by again. This is my representation of saying that knowledge flows from person to person, and it is not a one-way street. It also comes back from the trainees to the faculty. And I've certainly learned a lot from the people who worked on these, all of which have been junior to me, obviously, since I was not allowed to participate in these autopsies. I did look at the microscopic, but you have to keep an open mind and continue learning. That is all I have for this one. If there are any questions.
I'm still waiting for the questions, but I think maybe at the end of your second lecture, we have the more questions.
Sure. Oh, I know. COVID is difficult. So I was wondering if you have done any autopsies, COVID autopsies in Pakistan. Anybody has?
I don't think so. Maybe in CMH, but I don't think so.
Okay. Is there a reason why you would not do them?
I don't know exactly, actually.
I know the custom is that people.
Yeah, the main reason is the custom and some religious beliefs.
Yes. I mean, they're also, I know one of my cousin's daughter died of COVID, and they wouldn't even let the body go home. They just said, "Why you have to take it to the Qabristan right from the hospital," and very restrictive. Yes. Actually, here too, the patients were not allowed visitors in the early phase at all. Something on the Q&A. We don't do autopsies in Pakistan. You know,
one question. Sorry,
yes,
sorry,
that is the question. So, you know, I've actually thought about this a lot because when I was in Pakistan, as you know, I went to medical school there, and then over time, as I've interacted with pathologists there and discussed this, I think part of it is educating the population and saying, even though people that, if you can say to them that we will only examine, it is like a surgical procedure. You can take biopsies if there's a problem of exposing it. You can explain it to the patient's family by saying, we will only take a core needle biopsy, like you would at a surgery, or we will only take, they don't want the organs maybe taken out. You can open up, dissect, close back normally. They won't be able to tell, but they will see the incision at the Husal time. So it's not an easy thing to do. I don't know. I mean, in a country where people kill polio vaccinators, to say you want to do an autopsy, I think is an uphill battle. So you won't.
Unfortunate.
It is unfortunate. And then to be able to learn, the main thing the problem that I see with not doing autopsies, having been here obviously all these years and never having done an autopsy in Pakistan, is that when mistakes are made, nobody knows about it, because it's only the autopsy that tells you, was the clinical diagnosis right, really, or what else happened. And that won't happen. That won't be. Nobody is held accountable for the mistakes that have made, because those are not looked at. And here, you know, we do autopsies. At our institution, we are about a 530 bed hospital. We do about 180 autopsies, 170, 180 autopsies a year. So,
Okay.
yeah. All right.
So we should go to the next lecture.
Yes, certainly, if you will just give me a second to look, I'll make sure. Okay. All right, so I have to, wait, I want to bring this here. But now I can't see there's a lot more showing up on chat. Okay, share screen. Oh, I should probably first let me close wait, I don't want to share the screen. First, let me close this. Okay. Now. Okay. Can you hear me? All right.
Yep.
Yep. And see the screen?
Yes.
Okay, perfect. So this format is a little different than what I've been showing you before. So I was doing a straight PowerPoint before, and please move this window away. Anyway, I don't know what all that is coming up. You are seeing some extra things, but ignore the top, all of that. So this platform is called Path Presenter. And I don't know if any of you have used it or are aware of it. It is a platform that was developed about 4 or 5 years ago by a pathologist in conjunction with IT people. And it allows sharing of virtual slides. It has a gigantic amount of memory. So whole scanned slides can be scanned into it. It's a long process. You have to scan them and then transfer them in there. But then they are there. So it has a public component and a private component. You can pay for private storage on it, but these presentations are on the public component. And if you go to pathpresenter.com and find them, there are many, many, many presentations on it now. Not just presentations, but slide collections. The only thing that they ask is for me to use it, the only thing I have to do is I have to put it on the public, and I have to annotate it so that anybody looking at it knows what you are talking about. So although all the diagnoses are not in here right now, we will add them to it after the presentation so that it is there. And that is the link that I had sent you earlier, was just the cases. I don't know if anybody got a chance to look at them, but I hope some of you did. The presentations, the links will still work after the presentation, and you can go back and review them, because sometimes one doesn't catch everything as you're going through it. Okay, so I want to acknowledge my resident who had said she would come in, but it's still only 6 o'clock in the morning here. Heather was amazingly helpful in helping me find the cases and then do all the technical, not only just the technical stuff of getting everything scanned, which our secretary does, but she has to, one at a time, you have to manually upload the slides, and it takes a while to do it. And then also putting together the slides with it. And I'm really appreciative of all the work that she's done. Okay, so let's move this away. All right, the first case was a 10-month-old with developmental delay and progressive respiratory failure, initially diagnosed with RSV. The chest X-ray showed a posterior mediastinal mass extending into the paraspinal region and underwent a biopsy. The story is, very typical of a mass, a posterior mediastinal mass in a 10-month-old. And this image, you can see it is really a huge mass, as you can see here. Your differential would, of course, be neuroblastoma. So looking at the slide, I think all of you...
Excuse me, Dr. Alia.
Yes.
I think your screen is showing, but we are not seeing the slides actually.
This is not showing? Okay.
Yeah.
Let me try over again. I'm going to close this, move this screen away. Okay, wait, I'm going to close and start over because that is not good. Okay, how about now?
No.
No, okay. I need to close that. I'm going to close everything. And okay. Okay, how about now?
Yeah, now it's good.
Oh, good, thank you. Thanks for telling me that. Okay, so let's go back to what it was not showing before. So the case history I'd already read. The X-ray, you can see there's this gigantic posterior mediastinal mass. And now, so you see the beauty of this path presenter. These are not still images. This is the whole slide that I had submitted. So I can scroll around, I can move it, I can show you what's going on in real time. And you can insert the PowerPoint slides in between, which is a new thing I've learned today. As I said, you continue learning. Here's my resident teaching me how to do this. Okay, so the purpose of my presentation today for this whole hour, it is not how to make a diagnosis in a small blue cell tumor or what pediatric tumors are, but more focusing on post-therapy evaluation, because I think that is a topic that we don't address enough. And you probably would be seeing a lot of these cases in which there is therapy first, and then you move on to as resection is done. And you have to remember, you have to know what the parameters are for looking at it. All right, so beginning here, the very first case, easy to say that there is neuropil in the background, and you can go even higher power with showing you these rosette-like areas. And the small, and here is Heather in the background. I just thanked you for all that you had helped me to do.
Thanks.
And we're just continuing with we're at the first case.
Oh, okay. Can I have the link?
And the Zoom link. Yes, let me send you. Actually, you know, if we both sign in, there will be a lot of back thing. Why don't you keep the Path Presenter up and then look here, because it's going to be exactly the same as Path Presenter.
Sounds good. Okay.
Okay. Okay. So I had hoped that the participants would be able to speak as well during it, but maybe we can keep, it may be okay to have all the questions at the end, but there's certainly, so this was a wedge biopsy. You can see one area looks like typical neuroblastoma, whereas this piece is a little bit different. There is more maturation. There is neuropil in the background, but certainly ganglion-like cells are many more. So there is some area of necrosis, but not much, no calcification. And an area like this, you would have no trouble calling that a maturing neuroblastoma. But with the two different areas, do you remember how this case was signed out as?
Yeah, it was called, here we go.
Thank you. So this one was called Schwannian stroma poorly differentiated intermediate MKI, but overall, given the age, this was a favorable histology. And I think you would all agree that the Shimada grading, you use all the time, and we do too. I'm not going to go through how to do it, because that is not the purpose of this presentation. But it's good to know, to have it in front of you and say, how did that apply? How did we come to favorable histology in this one? Okay, so moving on from that, what happened to this patient? Given that he had such a large mass, he had 2 cycles of chemotherapy and then underwent resection. Here's the imaging. After the 2 cycles, there is still residual tumor here. And you can see it's markedly less. These may be 2 separate nodules. We don't know that that big tumor was masking it, or are these the 2 areas of residual tumor are of the same one? There was a single primary, and there are 2 foci of residual tumor in this patient. And when you look at the resection specimen, there are, so it looks very different than excuse me, what we saw first. There is much more maturation, as shown by large amount of cytoplasm. The nucleus is to one side with a prominent nucleolus, meaning this is becoming really ganglionic. Here you might even say that there is a satellite cell around it, maybe another one here. So it's starting to mature towards a ganglion cells. However, as you move around, you would appreciate that there are still other cells that did not mature so much. They look like neuroblasts. Here they are, forming clusters. And then again, more that are maturing. So how would one, so see, these are the sort of things that I would have stopped to ask the audience, how would you call it and what it is? But I want you to think about all of these features when you have a treated neuroblastoma, how this would be called. So I think at this time, it is still a ganglion neuroblastoma, or a neuroblastoma with differentiation. So what the key feature to remember in post-therapy neuroblastomas is that these tumors can undergo necrosis, meaning they can be totally necrotic and done, leaving behind, or partly necrotic, leaving behind fibrosis, hemosiderin, and calcifications, which are very common in these post-therapy tumors. And then, but you have to assess how much of the tumor is viable, how much of it is Schwannian, how much of it is immature still and maturing, because that will decide whether you are going to call it a ganglioneuroma, a ganglioneuroblastoma, or a neuroblastoma with post-therapy maturation. Because the important thing to remember is that the Shimada grading that we've talked about for the primary tumor, untreated tumor, is not applicable for post-therapy. No aspect of it is applicable, because now it doesn't matter. The changes that have occurred do not correlate with prognosis, really, with just a couple of exceptions. One would be if there's complete necrosis and no residual tumor. That is not part of the Shimada grading anyway, but that is a different prognostic feature, that the patient is totally cured. Or you can say that if it is completely mature, that the patient has a good prognosis. So the features that we are evaluating are Schwannian stroma, to call it, or how to call it, the amount of maturation, saying is it completely mature or are there still neuroblasts left? If there are any neuroblasts left, I think calling it a ganglioneuroblastoma is appropriate, and calling it post-therapy ganglioneuroblastoma is how I would phrase it. And you don't do an MKI post-therapy. It's just not relevant, because the dividing cells will all have died. So this is from a paper co-authored by Dr. Shimada, studying, and I'll give you the reference later on, is looking at patients who had post-therapy resections, comparing them to the pre-treatment. Here is one, the imaging shows you a large pelvic mass, and that's the biopsy of a neuroblastoma. And the tumor has shrunk post-therapy, and on H&E, you can see that the most of the cells are dead, but there are still some viable cells, as seen in our case. You can also, oh, I see the down arrow. Does the down arrow not work on this? It doesn't. I thought it would. Nope. You have to click on it. Okay. It is still loading. Okay. So that was the first case, to show you maturation, partial maturation after therapy. The second patient illustrates a different amount of maturation. This is a 17-year-old male who underwent chemotherapy and radiation for neuroblastoma a long time ago, when he was 16-month-old only, and had no issues after that. He was treated and was fine, disease-free, with normal life. When he developed at age 16, he presented with exophthalmos and mediastinal and apical masses. That was biopsied and was called a lymphoma. That was appropriately treated. Then at age 17, he was shown on follow-up imaging to have a posterior mediastinal and apical mass that had persisted after the chemotherapy for the lymphoma. And this image shows you that there is a mass here in the posterior mediastinum and in the anterior chest here. So now the question is this lymphoma, or is it any of the neuroblastoma that he had been treated for in the past, or is it just scar? Looking at this case, this was excised, and that is what you see. If you look high power, appreciate that there are no neuroblasts and there are no lymphoma cells either. The whole tumor is composed of mature ganglion cells seen here, abundant cytoplasm, nucleus to one side, and a nucleolus, and a background of Schwannian stroma. Not really much neuropil seen as you would in a with neuroblasts. So looking at this, you would call it a ganglioneuroma, and that's all that this patient is. So when you get a post-therapy resection like this, these tend not to be very large. Like this one was under 3 centimeters. You should really section and submit it all, because what you're looking for is there any residual viable tumor here? So it would be really important to section everything and take a look. And H&E is enough. There is no need to do any special stains in this situation. There is no molecular studies. There's really nothing but inking the margins and submitting the tumor to say what is going on. And here from that same paper by Dr. Shimara shows you a patient with different responses. Like the first case I showed, there was our case similar to that. There was a lot of, there's a neuroblastoma, and then post-therapy, there's complete maturation into a ganglioneuroma, and like the case number 2 that I've shown you. And on imaging, so now if you look at the imaging from this patient, the mass is persistent throughout, even though it has completely matured. So the way to think about that is that all these small cells, if you know, there are 1,000 cells in this field. If say 99% of them die, and there may be 10 or 20 left, or 100 cells left, a few cells left, and they mature to these cells that are now, each cell is several times the size of that small cell. And then all of the stroma that's filling it, that is what is occupying the space of the tumor. Even though the majority of the tumor is dead, the ones that mature get larger. So based on imaging, they cannot determine whether the patient has had complete response or not. And
16 years after the primary tumor.
Right. And then 16 years exactly after the primary tumor, you would expect it to be mature or should have progressed maybe. Anyway, so to show you that maturation is seen on radiology as a mass. In addition, it can also be MIBG positive. So that doesn't tell you. So in this paper that I've been talking about, they described 18 patients, intermediate risk stage 3 tumors, all underwent chemotherapy or radiation. 2 had complete resections, while 16 had subtotal resections and post-op chemo. Histology was available for 10 of these. 4 had regression, as I described, necrosis, fibrosis, hemosiderin in all 4 of them. And 60 had maturation, with or without development of Schwannian stroma. So the masses were still there, and that's what accounted for the mass. The pre-therapy histology did not predict what would happen to these. So it did not matter what it showed, how much maturation there was before, what will it show afterwards. So there's no way of knowing except for taking the specimen out and doing a pathologic examination. So only then can you say that is this stable or regressing disease. So pathologic examination is actually key. Oops, that also was that. Okay. So just to give you a little bit of a break, this is a University of Michigan museum that I happen to go to. It's just so strange, modern art and me I don't understand it. So when you don't understand something, like you might get a specimen and say, I really don't understand what's going on. The only thing you can then do is describe. We don't understand how the parameters of a post-therapy neuroblastoma would affect prognosis, but we as pathologists are good at describing. So you will describe how much maturation there is, how much necrosis, and then leave it up to the clinician to use that information to take care of their patients. All right, so that was the series of neuroblastomas. And I guess the questions are all at the end. So I'm going to keep going, this Zoom format. Oh, well. We do the best we can. So case 3, maybe I've summarized enough. I think you've sort of gotten the message for what it means for post-therapy neuroblastomas. For case 3 now, this is an 11-month-old female with a large abdominal mass. She underwent 2 cycles of neoadjuvant chemotherapy with significant reduction in tumor size. So I'm not sure what you follow in Pakistan for the treatment or not. So in the US, large abdominal mass, it was in the kidney. We would have, they will resect without therapy if it is resectable. The only time that they do chemotherapy here before surgery is if the tumor is so large that they think that they cannot safely take it out and they would like to decrease the size. Remember, this is a patient that has no diagnosis, just has an imaging and shows a tumor in the kidney. Or if there's already been spill in the abdomen, but they will want to resect it, they will treat first and then take out the tumor. Whereas in Europe, the attitude is different totally, right? The SIOP protocol is chemotherapy first, and then they do the resection. So in a patient like this, in which they did treatment first and then the nephrectomy, this is the cut section of the tumor that shows you variable areas. Some look much more red and viable looking. Others, these bright yellow, are probably totally necrotic. Then there are some that look more stromal maybe, or tan, red. For sampling, post-therapy Wilms tumors, which will what we assume that this is, you sample it using the same protocol that's published that we use here from COG, and the SIOP uses the same, that you have to map where the blocks are taken from. And you ink the surface, you cut the slices, you take your sections, on average 1 per cm, and to include the periphery of the tumor, the hilum, and any vessels and a ureter like you would any other. So here is the rim of the tumor. You can see the tumor is really large. You can hardly, there's maybe some fat or vessels attached here, but you really cannot barely see any residual kidney at the rim. So you would take sections from this area, and then you have to sample all the different looking areas. And here this resident has nicely labeled where the sections are coming from. So in our institution, we take a photograph, because with the digital it's very easy, and they can label onto it where the cassettes were from by putting in text boxes, and then they put it in file. So I can go back, today I can go back for the last 5 years and look up any case that had a gross picture and see how was it sectioned and how were the sections taken, because those are filed in our archives. Okay, so looking at this section, first of all, you have to recognize what is normal here. So I assume you can all appreciate that here is the normal adrenal. This was a radical nephrectomy. The adrenal gland itself is not involved by tumor. For normal kidney, I don't think I can see any normal kidney, because this is now tumor that's extending out towards the adrenal. So already you have some staging parameters here saying that the tumor is infiltrating almost into the adrenal capsule. All the sections that we took showed it just adjacent to it, right there. So you can see there's the adrenal capsule and there's tumor right there. So there's definitely spread outside the kidney. Okay, the second thing we can do is make a diagnosis. We actually have not made a diagnosis because this patient was treated and then resected. So looking at the tumor itself, appreciate that you can see that all the 3 components of a Wilms tumor. There's the blastema. Within that is also that epithelioid component in here. And then there is stroma. So you would look at that. Lots of lymphocytes in the stroma, basically. Hemosiderin and lymphocytes, as you would expect in a post-therapy patient, because a lot of this has regressed, maybe even a couple of eosinophils. Here is the epithelium, disorganized. Maybe here there is some stroma of the tumor stroma is still here. So we are confident that this is a triphasic Wilms. Then the next thing you would do is look for anaplasia anywhere. So there, in all the sections that you've taken in this patient, there was no anaplasia. So that was easy enough. Now, what other things do we need to look at with this patient? So we've said that here is an area of necrosis. So when you sample a tumor, our tendency obviously is to stay away from the grossly necrotic areas. So what that ends up happening is that we undersample the necrosis. And if you were to depend only on your microscopic description, you would not be able to say how much of the tumor was necrotic. So percent necrosis is important in post-therapy evaluation of WILMs. So you have to take both the gross description and the microscopic sections to kind of estimate what percentage of the tumor is necrotic. I mean, it is truly still obviously an estimate because you're not actually measuring and calculating. You look at all your cut slices and you say, well, okay, 1/3 of the tumor was necrotic, I think in this case, approximately. These areas which have there is clear tumor response because of the presence of macrophages, these hemosiderin-laden macrophages, and some fibrosis. That doesn't count towards the necrotic bit. It still is a tumor response. You would only count how much necrosis there is by what looks necrotic. Then you have to then decide what is left behind, the viable tumor. What is that? And that brings me to a really good point. Looking at these, so what happened was that when I initially looked at these cases, I said, this is a triphasic WILMS. There is still a lot of stroma. And I did not think that this was blastemal predominant at this stage. But then when I went to other sections, so you do have to look at all the sections before you make up your mind for anything. Here is another slice of the tumor. Appreciate the normal kidney here and the tumor infiltrating in here. And so there was other sections taken from this more red-gray areas that showed that indeed this tumor has a lot of blastema. So it is still triphasic. There is epithelial component and stromal component, but the dominant pattern is blastema. So this would be called blastema predominant. Look here. So for example, you have whole areas that are only blastema. And even in the intermixed areas, the prominent component is the blastemal component. And that's important because if more than 60% of the tumor is blastemal, it puts it in an intermediate risk category. Okay, and I'll show you the table of how to put it in the risk groups shortly. So this is another WILMS tumor, a 4-year-old with an abdominal mass who underwent radical nephrectomy after 4 weeks of neoadjuvant chemotherapy. So I'm showing you 3 different cases of WILMS tumors because each one illustrates a different issue as you evaluate the post-therapy WILMS. The first one showed you blastema predominant. Now the second one, which is this case 4, here is the gross picture. Appreciate how necrotic and hemorrhagic the tumor looks. And the tumor is small. Look at this. All of this yellow is probably dead tumor. Look at how much necrotic tumor is here in what looks like the ureter. So you must sample all of these areas to see is there really tumor in the ureter, because that would make a difference in the staging system, or pelvis really. Here is the pelvis open. There is the ureter going down from here, and there is tumor right here. So these sections, these blocks need to be blocked here, and definitely the tumor is infiltrating into the hilum, but you have to figure out if there's any viable tumor here. And then of course you will take sections of the tumor. Here is one of those. And the majority of the tumor looks necrotic, or at least non-viable. Here it is with some stroma or fibrosis, some macrophages, blood vessels. If you had only this, you could not even make a diagnosis of WILMS tumor here. There is so little tumor. Remember, we still have to make a diagnosis because this is still a post-therapy tumor, and we haven't done that. Oops, we haven't done that yet. I need to show you areas where there is viable tumor to first make a diagnosis. There's the pelvis where the tumor is going into. And as I look at it, this is just stroma, which has matured also. Maybe here. So to even make, then you'd say, oh, are these residual tubules from the normal kidney? Is there any blastema here? I don't think it's that clear. Maybe even here, are there any tumor cells in here? Are these just macrophages? It's kind of hard to tell where there is viable tumor, but I think other sections did really show that there definitely is viable tumor. Maybe some here in between, or here. Even those look like blood vessels to me now. Anyway, so you would have to search around and look for viable tumor and say, well, that this really is Wilms tumor. And I think we did do that. The reason for selecting this particular, here's normal kidney, to say even the adjacent kidney will show you compression effect. There are a lot of fibroblasts here between the glomeruli and the tubules. And you also would then be looking for nephrogenic rests, which would persist here. I don't see any here. The reason for selecting this particular slide to show you is that there is an area here that I wasn't sure whether this is residual tumor or is this nephrogenic rest, which you can see in Wilms tumors, because this actually would make a big difference to there being viable tumor or not, if everything else was necrotic. Okay, so I don't actually see that many treated tumors. We see, being in the US, we see pre-treatment Wilms. And so not having seen many of these, I see less than one treated Wilms a year. I would say one in every few years. So I did send this out to the National Wilms Tumor Study Group, to Dr. Perlman, who is also in Chicago, to see in her experience what she thought. So I do defer to her. I don't know that I could make this call on my own, because this really looks very mature. And she did call it residual Wilms tumor, because that is actually, there were only 3 slides that had this lesion. Everywhere in the middle was what this looks like, meaning fibrosis, hemorrhage, hemosiderin, and nothing else. So to determine these, and a couple of other, 2 or 3 other little foci, also only at the periphery of the tumor, that these are really tumor with complete resection, puts this patient in the low risk group. Okay. So moving on, this is the comparison between how we evaluate. The COG evaluation is the pre-therapy evaluation, and the SIOP, the International Society, mainly the European, is the post-therapy. So you have to decide what kind of specimen you have to use which grading system. So using the SIOP, if it was completely necrotic, it would be a low risk, or if there was a cystic partially differentiated. If there was any of the epithelial, stromal, mixed, or regressive types, would be intermediate risk, or if it was focal anaplasia, would be intermediate risk. So the first patient falls into which had residual tumor going out into the periadrenal, but all margins were free, would fall into the intermediate risk. So does the second one, because there is epithelial, residual epithelial. Now we look at the third case, or the third neuroblastoma case, nephroblastoma case. This is a 3-year-old with a large abdominal mass and pulmonary nodules, which they thought clinically was consistent with Wilms tumor. He received 4 weeks of neoadjuvant therapy and then underwent nephrectomy. And here is this patient's tumor. So here, appreciate how much maturation has occurred in the tumor. So you can see the tumor here. You know what? I will summarize at the end. There's a lot of maturation. And at the edge of this one, to compare with the previous, are these nests, which we think are, which I also sent to Dr. Perlman, and she thinks that these are really nephrogenic rests. Now, would I be able to differentiate those two now that I've seen one case of each? I don't know. But sometimes you have to use your judgment and say, these are stretched out, they are outside the capsule of the tumor, this is where the tumor was. But this tumor had remained large because of the increase in size due to the muscle differentiation. And that can happen post-therapy as well. You can have pre-therapy skeletal muscle and increase in post-therapy skeletal muscle as well. So this one also fell in the, I'm going to go back to that table. And so now we've looked at 3 Wilms tumor patients. The second and the third both fall into the intermediate risk. But the blastemal type, which was the first one, actually, because greater than 60% of it is blastemal, falls into the high risk group. So that patient would get additional therapy, and the therapy and the follow-up would be different. So in post-therapy Wilms, it's important to say, is it completely necrotic? Is there anaplasia? Is it excised completely? What are the margins? And then is there blastema predominant or diffuse anaplasia, to put it in the high risk? So those are the things that you would be looking for. This was a study that shows that compares patients that had nephrogenic rests found post-therapy, found in patients, and what the risk was of developing tumor in the second kidney, which is relevant to, I'll leave this, we're going to run out of time. So I'm going to leave this reference with you, and you can look it up and say that, because basically what it says is that if you have nephrogenic rest, the risk of tumor in the other side is 18 times that, the relative risk is 18 times that of if you don't have, which is the first column here, of 1. So that it increases the risk of therapy. So identifying nephrogenic rest is important, also in the post-therapy specimen. Okay, so I'm going to move on to the next tumor, which is also, so basically I think that there are 3 main renal pediatric tumors that have very significant pathologic components to post-therapy evaluation. We've talked about neuroblastoma and Wilms tumor, and now I'm going to move on to the next tumor. And then there is a few smaller groups of tumors that are not as important, and we'll have them at the end. But this is a picture of sunset in Arizona. We're driving by earlier this year. Seems like strange that we really used to travel. This was in January of this year. So moving on to case 6, this was a 4-year-old male with a proximal humerus lesion, and I'll show you a pre-treatment biopsy that was done here. It has a classic radiologic picture of this Cardman triangle that we always talk about, and an infiltrative lesion. So actually the lesion is pretty big. It's hard to say. You have to compare it to the normal here to realize that the lesion is permeating through the bone, pretty much through almost all of the bone. But with that image, this really has to be malignant, even though the biopsy is suboptimal and not the best since it's a core needle biopsy. Looking at this, I mean, this would be another area where I would have asked you what you thought of it, but since I can't ask you, I will describe it to you and assume that you agree with me. Here are really atypical looking cells. There is fibrosis, and then there is very clearly abnormal osteoid deposited here throughout. And even though it's not very cellular, it's cellular enough. I think each one of us would be comfortable calling this like here, saying that with this osteoid, with these atypical cells, with that radiology, the age, the location, everything fits, and this would be an osteoblastic osteosarcoma. So this patient then was given chemotherapy, and because of that extensive tumor, he had to have an amputation and a shoulder disarticulation for tumor dissection. Now, this is really extreme. We do see this occasionally. They will try and do limb sparing procedures and try and resect only the compartment. But if the tumor is that big, then you don't. So grossly, when you get the specimen, of course, you have to ink the margins and assess those. The soft tissue margin was free, as seen here, and the humeral head here. But so what we do is we take the soft tissues and for our margins and specimen. We take the specimen and freeze it, because that is the only way it allows you. There are two ways of cutting these specimens, right? You could fix it first, but that would take a long time for fixation. We freeze them overnight, and then the next day they are they're frozen in liquid nitrogen, I believe, right? And then you take a bone saw and cut slices through them. This allows you to look at grossly the extent of the tumor, and then you can take those slices and fix them. And you select one slice, which is the whole face of the tumor, and you have to block it all. So you have to map it. Here's another one in which we've taken a photograph of it and said, so the pictures with the blocks are going, sequentially like this, blocking each of these areas. And I'm going to show you A20 to show. So most importantly, you have to, post-therapy osteosarcomas, you have to block one whole face to estimate how much necrosis there is of the tumor. Now, looking at this, comparing it to that pre-therapy tumor to now, I think we only found maybe these two foci. I think there's one here and one here. Very rare. So greater than 98% of the tumor was gone. And instead, it is replaced by fibrous tissue or granulation tissue with these thin-walled blood vessels. There are bone spicules, most of which looks not rimmed by malignant cells, but there are some nuclei in it, but you don't call those viable tumor, I don't think. So looking at the marrow, there is very little viable tumor. So this would be greater than 98%. So there are two cutoffs that you have to remember when you are evaluating for necrosis. Greater than, so 100% is one. Then greater than 90% necrosis is a key limit, or greater than 60% necrosis, or at least 60% viable. So 60%, 90%, and 100% necrosis are what determine next steps for the clinician. So you have to really, that's why you have to block the whole thing. You have to look at it. You have to see where it's extending. Is it going anywhere else? This is just granulation tissue in the periosteum. As you can see, I do a lot of heart. And so you would really carefully look around. Again, all of these diagnoses of post-therapy tumors are on H&E and extensively sectioning. You don't have to do any special stains or anything on this to make a diagnosis or to do a proper evaluation. So there is this study, which is really, it's an older study, but it showed, this from 1994, but this is the gold standard of what they base all of these prognostic and therapeutic decisions on. There were a total of 355 patients with high-grade osteosarcoma. 309 received chemotherapy, and then they divided them from response into good, which was greater than 90% necrotic, fair, 60 to 90%, and then poor, 60% necrotic. They also looked at the margin status, with calling it wide or adequate or tumor present at margin. Of these 309 patients, 28 developed local recurrence during 4 years of follow-up. None of the radical resections developed recurrence, which is why radical resection is the treatment of choice. However, you don't want to have excessive resection. So you want to pick the patients appropriately for subtotal amputations or limb-sparing procedures, which really, these are kids, a lot of them. You don't want to do amputations on them if they can have a normal life expectancy without an amputation and return. So the first choice would be a limb sparing. So then how do you decide what the prognosis is going to be for this patient? So if the margin was wide and the response was good, only 1% recurred. So that is the goal of doing chemotherapy first and then doing a resection of the compartment with a wide margin. If there was less than a wide margin and poor response, meaning less than 60% necrosis, then almost half of these patients developed a recurrence during 4 years. So the pathologic examination of the specimen is really key to determining what's going to happen. But in osteosarcoma, the other thing that they do is they follow these patients for a long time. So this patient was admitted for respiratory distress at 10 years of age and was found to have an intrahilar mass. He underwent additional chemotherapy and then a resection. So we see this a lot also, to have tumors, both Wilms tumor and osteosarcoma, that metastasize to the lung. If there are oligomets, the intent of the resection is curative. And they have found that if you can go cherry picking after these tumors, if you take out as many of them or all of them, even if there are 3, 4, or 5 of them, they keep going back and back and back and taking them out because those patients do well. The thinking is that the cells seeded at the time of the original tumor growth, and only if maybe 4 or 5 of them seeded and they're growing. It's not that they're still coming from the primary. The primary is being taken care of. The metastases are from them, and then those can be resected. And this shows you very clearly this patient that got chemotherapy, the tumor now is totally necrotic and the margin is free. So when you get these mets, you need to look at how much of it is necrotic and is the margin free, because the intent is curative and you need to examine the margin. And those are the 2 main things that you will respond. So this one is 100% necrotic tumor with clean margins. Okay, so I'm going to move on to the last group. And this is actually sunset from my building earlier this year. You know, I've been home so much. I've been taking a lot of pictures around the house. I live in an apartment building in Chicago, and this is looking out from the family room. This wall is my living room wall. And what you are seeing, there's the Sears Tower, by the way. The sun sets on the west over on this side. And what this is, reflection. So this is my slide to say you have to reflect on what you've learned, because otherwise you don't really remember things. If you just my telling you things is not enough. You have to re-review, read again, and think about it so that you can incorporate the information if you didn't already know it, which, I mean, maybe you knew all of this already, but if there was anything new in this presentation, you have to really think about it and review it. And we will go on to the last 3 cases in the next 5 minutes or so. Okay, moving on. This is a 12-year-old with a periorbital mass concerning for a vascular lesion on MRI, but the previous biopsy was non-diagnostic. So they went in to do a biopsy. And this is what it showed. So there were actually more than one procedure done on this patient. First, there was a biopsy, then the patient was treated, and then the tumor was resected. If you had this, whether it is pre-treatment or post-treatment, if this was your first biopsy that you got, you would have to do the whole workup for what is this, blue cell tumor. It's not that small. Some of it is not that small. But maybe I can convince you that there is some rhabdoid differentiation here. I don't know if these are just really necrotic cells or some myogenic differentiation. Maybe here you can appreciate some. So this was a rhabdomyosarcoma. So in the initial biopsy, we would do chromosomal studies, fusion panel to see is this one of the fusion positive or negative. You would classify whether it was an embryonal or alveolar. I think this turned out to be a fusion positive, right?
I think so, yeah.
Yeah, a fusion positive, so we would have called it. It's actually now what they're finding is that the histology is not as important as the presence or absence of fusion. The fusion positive tumors are the poorer prognosis, so they would be treated much more aggressively. Then the patient got therapy, and this actually now is the post-therapy slide. And you can see that there is basically tumor everywhere. It may be some of the tumor cells are larger, and I think thinking of the pre-treatment biopsy, it was a little bit more cellular. But your diagnosis on this one would be post-therapy rhabdomyosarcoma with greater than 95% or 90% viable tumor. There is no set protocol for how to evaluate these. The prognosis is not as dependent, because for rhabdomyosarcoma, the protocol is to do a biopsy. If it's unresectable, you would give chemotherapy to try and reduce it and then resect it. And after the biopsy, if it was resectable, you would resect first. So there is no study yet that I am aware of, or that Heather could find, in which post-therapy evaluation made a difference to the continued management of these patients. So for rhabdomyosarcoma, you basically will give percent necrosis or viable tumor and give margins like you would for any other resection. Okay. Case 9 is a 17-year-old with a humeral mass. There was some response on imaging to chemotherapy and now underwent amputation and shoulder disarticulation. So here is the skeletal muscle, because the tumor was extending out into the soft tissues. And okay. So looking at this again, another small round blue cell tumor. Again, you would look at it and say, well, you have to do your diagnosis. So even though this is a post-therapy specimen, you still have to make a diagnosis. So you would do your usual IHC markers to say, what is this tumor? If it turns out to be a rhabdo, which would be, this is a bone lesion, I would think this would turn out to be an Ewing's. But if it was to turn out to be a rhabdo, you would still be able to do the post-therapy, you still be able to do molecular testing on it if it's available. I really am not sure how the molecular testing is altered post-therapy, because the cases that I have seen, the post-therapy specimens, as long as they're viable, give you good material for molecular testing. There should not be any technical problem in doing it. The technical problem arises if you have decalcified. So if you are going to be doing any molecular testing, you have to make sure that before you fix and decalcify the tumor, after you fix in formalin, that you take specimen and put it aside for paraffin embedding for molecular testing. We also take touch preps. Those actually are excellent for testing because there are whole tumor cells in it. They have not been changed, and we just air dry them and store them in a cool place. You can do a Giemsa stain if you want to just make sure that there is tumor on it, and then store it. You don't cover slip because you don't want to take it out. And then even 2 slides, which are highly cellular, will give you more than enough material to do all the testing that you need. So remember that if nothing else, you can keep touch preps for tests. But you have to keep non-decalcified tumor for it. So I think this case turned out to be an Ewing's.
They wound up calling it undifferentiated.
Or undifferentiated,
Yeah.
okay. At that point, so undifferentiated sarcoma is what this one, nothing marked on it, which can happen. So again, but you can appreciate that there are regressive changes. There is fibrosis, there's hemosiderin, but there is still so much viable tumor that is, you will describe these changes and leave it at that. There's no staging criteria for it. All right, now for the last case, this patient had an embryonal germ cell tumor with bilateral pulmonary metastases. This was in the testes, and so he did receive therapy, and then after therapy, resection of the lesion in the lung. So this is the third case scenario in which we get resections of the lung metastases, because if you can take them out, again, the patients will do well. So the most common mets that we see resected are osteosarcoma, because that is the most common tumor in kids that we see. And after that, I do see occasionally synovial sarcoma, not that often, but Wilms tumor and then germ cell tumors. So this tumor then, we submitted the whole lesion. There was a partly solid, partly cystic lesion. And this is the only thing we found in that specimen. It was not that big, actually. It was about 2 centimeters or less. And here is the cyst. It's hard to tell whether that is lined by what kind of epithelium, but it's really flat epithelium that you don't think is, I mean, I don't think it's malignant. And what we did find are some abnormal nests of cartilage here. The differential would be from, say, a hamartoma. It would be unusual for a hamartoma to be associated with a germ cell tumor, be this large in a child. Remember, most hamartomas present in adulthood, and it doesn't have that infolding of epithelial structures that you see growing adjacent to the cartilage. The hamartoma generally has cartilage and epithelium with it. So this, I think, shows you that this has completely matured. And that's what I see in a majority of the patients who've received therapy, and the germ cell tumor matures into what would be called a mature teratoma. So here your line diagnosis will be mature teratoma, and then you would explain that this is status post therapy of metastatic germ cell tumor. It's not that the teratoma is arising here. And again, margin would be important because this intent is to cure. And then lastly, I'm going to end with these pictures of the fireworks off the Navy Pier, which I can see from my condo. No fireworks this whole year, but hopefully we will have cause for celebrations next year once this pandemic is under control over the world. So didn't leave you much time, but a few minutes for questions. And I am available. I'm in no rush to go anywhere. It's only 7 in the morning here. And Heather and I will be happy to answer any questions that you have.
Okay, thank you very much, Dr. Alia. And we have few questions.
Yes.
First question is, for neuroblastoma, which one is better as a prognostic marker, MKI or Ki67, and why?
Aha. So from what I have learned and from what Dr. Shimara says, MKI is what he and the whole group had developed using the model that they had at the time. And they think that that is more accurate than the Ki67, because the Ki67 picks up nuclei that are in the pre-mitotic phase also. Because you remember how when you're looking at a slide of, say, of any tumor, there are more Ki67 positive cases than you actually see mitotic figures. So Ki67 is not equivalent to mitosis. So it's not as discriminatory.
Okay. One more question.
Okay.
I think this is a comment rather than a question.
All right.
No fireworks. What about love in the air?
We'll have to wait till February for that one too. I know. You know, love on Zoom. After all, here I am talking to, 60 of you, not even being able to see your face, but I still feel the connection. Okay. I appreciate that. Yes.
So no more questions, I think.
Okay.
So if someone is sending a question, I can send you in the form of email.
Yes.
Okay.
And
thank you very much.
Have anything follow up on email? Yep. Yes.
Yep.
Great.
Thank you very much, Dr. Alia. These were magnificent lectures. And I think in the next year, you will be physically here.
I hope so. If you invite me, I will be there.
Okay. Thank you very much. Thank you.
You're welcome. My pleasure. Thank you.
So this is all for today. And please do join us at 2 p.m. tomorrow. And we have 4 more lectures, 2 lectures from Dr. Abbas and 2 lectures from Dr. Anil Parwani. So see you tomorrow at 2 p.m. Thank you very much.